ஓகே, சரி. பொண்ணு ஓகே சொல்லிட்டா. இவங்கிட்ட கேட்டா இவங்க ரொம்ப கஷ்டப்படுறாங்க.
Hello, Anil sir, am I audible?
Hello. Yeah, you're audible.
Yes,
May
ma'am,
I
you
know
are
who is
audible.
this?
Yeah, thank you so much. Thank
Who is this?
you. This is
Ashwini?
Ashwini. Yes, ma'am.
Ashwini,
On the
you will have to be little more louder though, huh?
okay,
Because the
okay,
voice is a little faint.
okay. I'll do that, ma'am.
Yeah.
Yes, yes, you are.
Hello, Sridhar ji. Is it loud enough now? Wait, I was just being soft. I understand, Sridhar ji. I think they have given the unmute only for the speakers.
Yeah, now they unmuted all. Now it
Yes.
is fine, Vadnaji.
Thank you.
Perfect. Perfect.
Anil ji, you can continue to display the main slide, Anil.
Sure, ma'am.
Anil ji? Dr. Jyotsna and Dr. Purva, have you joined? Can you just raise your hand, and also if you could, Anilji, unmute them for a second?
Dr. Jyotsna has not joined yet, ma'am. I will wait 5 more minutes for everyone to join, and then we'll start the session.
Sure. Just unmute Dr. Purva and Dr. Jyotsna for a second so that we can ensure that they are able to speak and they have joined.
Dr. Poova is co-host, ma'am. Can unmute themselves.
Yeah, Dr. Purva, can you just
Yeah,
test your sound? And
yeah, I'm here. I'm here.
yes,
Are you able to hear me properly?
yes, I can. And
Okay.
can
Yes,
you
ma'am.
please confirm if ma'am has joined, because Dr. Vani may join late, so you will go first. You
I
have to
have
go.
told her. I had just had a talk with her, so she must be joining in a minute or two.
Sure, sure. Thank you, Dr.
Okay.
Anilji, please display the main slides, please. The Spear Academy slides.
Sure, ma'am.
Anilji, please display the slides of the session.
Yeah, ma'am. Yeah, doing that.
Please make it full slide, Anilji.
Is that full, ma'am?
Yes, it's visible as full slide. Yes.
Vandana ma'am, am I audible?
Yes, now you are.
Yes. Oh.
Can you start off, Anilji? We have participants already joined in.
Ma'am, I think we can start now.
Yes,
Shashi ma'am can join
Shashivani
in
ma'am will
a
join
while.
later. So you will have to start now.
Sure. Yes. So, very my test of all the speakers and I think all of us very good afternoon to everyone and thank you so much for
You're,
giving us
you're
your time
breaking.
for our
You're breaking,
COVID-19
Anil.
Academy panel discussion. And as
Anilji,
you know,
we
COVID.
can't hear you. We can't hear you and you're breaking, Anilji.
Is it better now?
Much better, but still it's not that good.
Hello.
Yeah, it's slightly better, but not that good.
Some.
Hello?
Yeah, connectivity issue, ma'am.
Yeah, but you'll have to
So,
put it in a place better.
yeah, audible, ma'am.
Slightly better than before, but not that good.
Okay. So, as you know, COVID-19 Academy is a joint capacity building initiative of the NIDM, UNICEF, WHO India, HCL Foundation, and Sphere India for volunteers and outreach workers across the country. We have a very special panel discussion planned today called Kangaroo Mother Care National under National Newborn Care Week. And for this session, we have a very eminent panelist today. We have
Anil, you're totally lost and broken. Anil?
Moderates this session. We have Dr. Vanna Bhatia with us.
Anil, you are totally lost. Your voice is gone.
Am I audible now,
Nobody
ma'am?
can hear you.
Hello.
Please come to an area where people can hear you, Anil.
Vanna, ma'am, yeah.
We can't hear you, Anil.
Vandana, you can
Vanna,
start.
ma'am,
He just
you can
concluded.
go with the session. Yes.
Okay, thank you, Anil. Can you please stop screen share so that I can start sharing my screen? Very good afternoon and good evening and welcome to all of you who have joined today for this special Newborn Week webinar. As you all are aware, this is to commemorate the Newborn Week, and we are globally we are celebrating the Newborn Week, or rather commemorating the Newborn Week, because newborn is one of the most important part of the life cycle. And this is the first in the series of the webinars for Kangaroo Mother Care. So I will We have an eminent list of panelists today. We have Dr. Shashivani, who is also known as the mother of Kangaroo Mother Care in India, because she is the one who has trained many of the eminent pediatricians, neonatologists, facility-based workers, community-based workers, and she has been the first one to start Kangaroo Mother Care and advocate for it passionately across India and even globally. So she's one of the main panelists of today. The other eminent panelist today is Dr. Jyotsna Srivastav, who is the head of department of pediatrics in Gandhi Medical College, Bhopal, and along with her would be Dr. Purva Goya, who is the associate professor at Gandhi Medical College, Bhopal. This will be followed by panelist Dr. Alpana Moe. She's from West Bengal. She's a staff nurse, and she's a nursing mentor who has lots of experience of Kangaroo Mother Care with various newborns and parents and community and at facility level. And then we will hear from the Gadchiroli team, Dr. Ashwini and Dr. Sameer, who will share with us the experiences from the field. So this is the sum up of today's session. I will be introducing in detail each of the speakers before they start their presentation. I would now like to give you some brief as to why we are talking about Kangaroo Mother Care in this series of webinar and why we are commemorating Newborn Week. So as you are aware, infant mortality rate in the sample registration survey data has shown that the infant mortality rate decline is not as good as compared with 2017. And although there are states which are showing good decline in infant mortality rate, and there are states like Kerala, Lakshadweep, Meghalaya, Mizoram, which have shown high decline. But we also have states like Chhattisgarh, Uttar Pradesh, Jharkhand, Madhya Pradesh who need a faster decline and a better decline from where they are today. And if you look at the newborn mortality rate decline, we are also at this point talking that we need more decline for newborn mortality. Now, why are we so concerned about infant and newborn mortality? So if all of us remember our own life stages, we were first newborns, and then we moved to the stage of being an infant, which is 1 year of age, and from there we moved to be a 5-year-old. So if we do not cross our first newborn days, which is at the 28th day, if we cannot cross our 28th day, we obviously cannot see our first birthday, and we cannot see our 5th birthday, and then so on. We cannot progress in our life cycle to be a healthy, good quality of life, productive adult. So that is the reason when we talk about within the life cycle, the newborn is one of the most important components of this life cycle. To achieve this newborn, and if we also look at the global goals of sustainable development, so to achieve a newborn mortality and an infant mortality of single digit is a big goal across the world, not only for other countries but also for India, and within India across the states. It is so each state has to achieve a single digit NMR and IMR, and only then we will be able to achieve a single digit NMR IMR for the country. Now, in the journey of newborn care, there has been a lot of progress. Although we are talking about need for a faster pace of decline currently, but we are also seeing a lot of progress within India and at different levels at the state. So in 1994, we started with the Child Survival and Safe Motherhood Program. And then in 2003, UNICEF and in the partnership of Government of West Bengal started the first special newborn care unit in Purulia. And we also piloted 2 newborn care units thereafter in 2008-9 at Madhya Pradesh in partnership with Government of Madhya Pradesh. In 2005, there was also a launch of the National Rural Health Mission, which today is known also as the National Health Mission. And it has both the urban and rural health mission as part of the program. And in 2014, we had the India Newborn Action Plan launched. And in between, in 2005, we also had the the Janani Suraksha Yojana, where which included the integrated management of childhood illnesses and increased importance to facility-based care. And nationally, the facility-based newborn care was piloted across 17 districts in 2005. And again, in 2013, there was also an India call to action for child survival and development. Today, what we see is a conglomerate of interventions, and these interventions include labor rooms across at up to the primary healthcare level, and these are 24/7 labor rooms with a well-equipped labor room and delivery point and newborn care corner. We also see the community health centers which have newborn stabilization units, and then we see the SNCUs. We are also seeing an upscale of referral transport for mother and newborn, which is also known as Janani vehicle in Madhya Pradesh, and the maternal newborn vehicle or transport vehicle across other states. And then when we see these causes of newborns deaths, so what are these causes of newborn deaths? First, let me tell you, newborn deaths account for, in many states, 60 to 70% of infant deaths. So many of the newborns are lost in the first month of life, and that is why we lose that many babies who do not see their first birthday. And within the first month of life, we lose these babies in the first day or day zero of birth, which we call. And this is where we are hoping to have intrapartum care strengthened, because that is where we are emphasizing on quality of intrapartum care during labor. And this is the main cause of death in the first day of life is birth asphyxia or difficulty in breathing among newborns. Other causes could be low birth weight and preterm newborns, which do not attain their maturity level as per the age, because they are born earlier than 9 months, as we know colloquially. And we also have newborns which may be born with less than 2.5 kg of the ideal birth weight. And another important cause is newborn sepsis, which is 6.5% across globally, and in many states like MP and other states, we also see between 18 to 25%. Similar little other causes, also known as congenital anomalies or injuries at birth or other infections, also may be the reasons for newborn deaths. And between 1 to 59 months, where you see in this purple side of the pie, there could be other reasons for loss of children or newborns, which could be malaria, infections, congenital anomalies. So across the globe, there is a document called Every Newborn Progress Report. Across the globe, there are different newborn mortality levels. So if you see any country or any state which has a newborn mortality more than 35 or 25 to 35 per thousand live births, that is how the newborn deaths are counted. So you would see that many of them have sepsis, birth asphyxia, prematurity as the major causes, and other causes would be, depending on where their mortality stands. And if you look at in MP and India, like I was saying, every state today has SNCU. We have an SNCU online MIS. We have a referral transport. We are also looking at a centralized referral transport center, which monitors how the ambulance goes and picks up mothers for delivery and drops them back, or a sick newborn for any emergency care and drops them back. And we also have primary health centers with a lot of delivery points. So various levels of newborn care is there at different points of care, and this is newborn care corner, a newborn stabilization unit, a special newborn care unit, a newborn HDU or high dependency unit where mother and baby are kept together, and a follow-up OPD. So these are important milestones. And if you look at, there are various guidelines released by the National Health Mission to ensure that mothers and newborns survive intact. And many of these guidelines, I'm just sharing with you a screenshot of the National Health Mission website where you can access many of these guidelines. So some of the important guidelines which have been implemented across states is, one is the India Newborn Action Plan, Then we have the most important, which we are talking about today, is the kangaroo mother care and optimal feeding of low birth weight infants. Among others, also happen to be antenatal care, steroid use in preterm labor, home-based young child care, facility-based newborn care, the Rashtriya Bal Swasthya Karikram, Janani Suraksha Yojana and the Janani Suraksha Karikram. And we have also the IMNCI guidelines. So many of these guidelines are contributing to a lot of interventions for newborn health. And the Every Newborn Progress Report is also now emphasizing on the need for both maternal and newborn mortality. And here we are trying to engage with all of you as civil society so that we can harness the power of parents, families, and communities and engage with society to reduce these preventable newborn deaths and achieve the sustainable development goals. Quality of care happens to be one of the major new milestones which is emphasized by this Every Newborn Progress Report. And when we say quality of care, we are talking about pre-pregnancy, pregnancy, labor, and postnatal care. So I'm just sharing with you an example that what are these pre-pregnancy interventions. We have demand for family planning, antenatal care visits, quality of antenatal care visits. We have institutional deliveries and cesarean section delivery, postnatal care, and early initiation of breastfeeding. And also, when we talk about essential newborn care, we have key interventions which are very simple to do at home. So when a newborn comes home, we need to ensure that we keep the surroundings clean, hand washed all the time before touching the newborns, before feeding the newborns, or after cleaning the newborns. We ensure that early initiation of breast milk happens at first hour within birth, and the newborn is taken, healthy newborn is taken from the before even cutting the cord to the mother's chest, so that the baby can get skin to skin contact, have a the breast crawl, and start breastfeeding. Ensure exclusive breastfeeding for 6 months. Ensure warmth for the newborn, and ensure that the cord and eyes and ears are well taken care of. And the first immunization of oral polio, BCG, and hepatitis B, as well as the vitamin K1 is given to the newborn. Along with that, we have to ensure the counseling of the mother for early danger signs and ensuring them to come to the hospital. But besides this, there is also at facility and community the need for sick newborn care. So any low birth weight, preterm newborn, or those with breathing difficulties or any other anomaly, they are identified earlier and admitted to a unit known as the special newborn care unit. And from there, we also, after discharge, ensure that they come back and they are followed up at facility and home-based care. And now with COVID-19 in the picture, we are also looking at many of these guidelines being revised and reviewed based to ensure that COVID protocols are being followed across the facility. And we will hear from our people, from our panelists shortly. So some of the snapshots I'm trying to show that where Kangaroo mother care is started is usually at the facility, like a sick newborn care facility for low birth weight and preterm newborns. And from there, we are shifting them to a functional NHDU, which is a high dependency unit. Here in the photograph, you can see that. And also ensuring the mothers continue at facility, learn how to do it at facility, and then they go back home. And ASHAs are following them up through home-based young child care and through ensuring that at home the mothers will continue Kangaroo mother care. And this is some of more of the pictures of the special newborn care unit, which you can see, and how the Kangaroo mother care is given at facilities. And there will be a video towards the end, which we will share with you, and how they monitor the Kangaroo mother care using the various registers. And if you see Kangaroo mother care, if it is given well, you will notice there is a mean weight gain. There is no, among low birth weight babies, it's good weight gain before they are discharged. And daily they can gain weight up to 10 to 20 grams, especially the low birth weight babies, and they can be discharged earlier. There is bonding. So we will hear from the panelists the importance of Kangaroo mother care. And this is just a snapshot I was trying to give you a sense as to where the session is leading and why we are talking about Kangaroo mother care and newborn. So I will introduce the next speaker now, Dr. Jyotsna. Hopefully she has joined. I was not following the chat, Anil, so if you could just update to me, all the participants, have they joined? So,
Dr. Vandana, Shashivani madam has joined.
Join. Okay. Okay, great. Very, very happy to introduce our first speaker of the day, Dr. Shashivani ma'am. Like I mentioned, she is one of the initial, we call her also the mom or mother of Kangaroo Mother Care. Ma'am, we have had the privilege of learning from you on how to initiate Kangaroo Mother Care for newborns and how to advocate for the same. And Dr. Vani ma'am is a emeritus professor of pediatrics at Pramukh Swami Medical College, Karamsad, Gujarat, and the former president of National Neonatology Forum. And she is the initial, the first crusader for Kangaroo Mother Care. So welcome to Shashivani ma'am. Ma'am, over to you. Is it possible for you to share your screen, ma'am?
I will try. Thank you.
Thank you, ma'am.
Yes. Are you able to see?
Ma'am, it's taking time to start. If you can click on, yeah, now we can see. And if you can show the full screen, ma'am. You can click on the full screen on the right hand side corner here.
No, it's gone.
There is a slide pointer here, which you can see. Yes, it's taking time. Yes, ma'am.
Return to meeting. Something has gone wrong. I don't know.
Don't worry, ma'am. It will. The screen may be hanging. Can you email me your presentation, ma'am? Maybe because of the slow network or the slow computer.
Can you give me your email ID?
Ma'am, I'm sending it to you in the chat box to you, ma'am.
Not able to get it. Are you able to see now?
Ma'am, not yet. The screen on your side is slow. You can stop it and start again, ma'am. We will be able to see it. I have just typed my email ID to you privately in the chat box, ma'am. No, ma'am. Don't sign out, ma'am. Just stop the screen and start sharing again, ma'am.
How do? I don't know. Oh. This
Sridhar,
came
can you
up.
help, ma'am? Dr. Sridhar, can you help, ma'am? Ma'am, please close the PPT completely again and then open it again. Please close the PowerPoint completely and then open it again. Dr. Purva, you are not the host anymore, so please wait for some time before we can unmute you.
That is also not closing.
Okay, ma'am. I'll just, ma'am, you can start speaking then and just close the whole. Now I can see you. You need to exit from the. You have clicked on the photograph, so that's why it is hanging. You need to click on outside the photograph. You will be able to close it, ma'am.
Okay.
Ma'am, you can email me your presentation or ma'am, give us 2 minutes. We can go with the next speaker if you're comfortable.
Yeah, please. Yeah, that
so,
is fine.
So, Dr. Anilji, can you transfer this to the other speaker, Dr. Jyotsna and Dr. Purva, and we will sort out the technical issue with Dr. Vani, and then we'll come back to Dr. Vani. So please, I'm inviting Dr. Jyotsna ma'am, who is the head of department, Gandhi Medical College, Bhopal, and she is one of the most senior members of the team, and she's also the first unit. She's heading the first unit which started independent Kangaroo Mother Care Ward in India in 1994, and she's currently the managing trustee. I'm sorry, I was reading the wrong bio. So Dr. Jyotsna is the professor and head of Department of Pediatrics, Gandhi Medical College, Bhopal for last 2 years. She has a teaching experience of 30 years, along with guiding 34 dissertations for masters in pediatrics with more than 30 research papers to her credit, and she's heading the special newborn care unit at Gandhi Medical College, Bhopal. Dr. Purva Goya, an MBBS and MD Pediatrics, is the Associate Professor, Department of Pediatrics at Gandhi Medical College, Bhopal. She has completed her advanced course in medical education and is also the author of scientific publications in reputed journals. She is a national faculty for facility-based newborn care and preterm care, and currently she is also part of the NNF and IAP, and they are doing a lot of trainings for preterm and low birth weight care. So welcoming both the presenters and requesting Dr. Purva ma'am to share her slides.
Dr. Vandana, it is Purva is coming. I don't know where is her video is, but I am seen as Dr. Purva Goya.
Okay. Okay. Dr. Purva, can you unmute Dr. Purva? Can you make her the host?
Yeah.
Yeah, Dr. Purva, can you please start?
Yeah, I'm sharing the screen.
Yeah.
So is my screen visible?
Yes.
Okay.
So good afternoon, everyone. So this is Dr. Jyotsna Srivastav, and I am going to talk about the Kangaroo Mother Care as the facility-based. As all of you know it very well, Dr. Shashivani was about to give the lecture on the Kangaroo Mother Care in the community. Like all of you know it very well, that anything we start from the facility until unless it does not percolate down to the community, it's not going to make much impact, right? And it is the other way around. Certain things are there which will make impact only once they are functioning in the community. And for that matter, we need to sensitize everyone in the community, whosoever is involved in the care of the newborn. Next slide, please. So today I'm going to cover very important aspect, that it is thought the only preterm babies and the babies who are there healthy, they only need to take care by the Kangaroo method in the community, but it is not so, right? How do this word arises, Kangaroo Mother Care? From where this thing has come? As you can see in our this, everywhere we have made a kangaroo. You know, kangaroo is a animal which is seen maximally in the Australia, and they are huge, more than 100 kilograms of weight, very big in size. But when they parturiate, their offsprings are very small, right? As soon as they come out, they just crawl up and then they enter into a pouch which is made in front of the female kangaroo, and the mammary glands are also lying there inside that pouch, and these children, they go inside, these offspring, they go inside, and then they grow, and within no time they grow up to offsprings and well good weight and height, and then they come out, jump out of the pouch. And this idea was started, and that gives the insight that can human children can be reared up like this. And it was, this idea was very successful, especially in cases of premature and low birth weight babies. So Kangaroo Mother Care, but we as human being, we are not having these pouches. So artificially, you can just make pouches not in something very big. You can just make a loose pouch of a cloth or any shirt or anything, and that can be used to provide a kangaroo mother care type of facility. That is why kangaroo mother care is a very simple method of care for low birth weight infants that includes early and prolonged skin to skin contact with the mother, or in case mother is sick or she is not able to do that, any substitute caregiver can be given. It may be a father, it may be a grandmother, or any female in the family, or any male person in the family. Second important component is the exclusive and frequent breastfeeding. As the baby is attached to the mother, mother is emotionally attached to the baby, so lactation is easy and effective. So she can exclusively breastfeed and she can provide frequent breastfeeding. And it is a very low cost, rather no cost is involved in the standard way of giving care of the stable low birth weight infant. Next please. So as we see, actually providing care, mother is comfortable, she is sitting, or after some time when she is mobile, in that condition also she can very well provide the kangaroo mother care to the baby. So first most component of kangaroo mother care is skin to skin contact, right? It is the best way to maintain the temperature of the baby. The second component is the breastfeeding, and third is follow up after discharge. She has to come for the follow up after once she is being discharged, and depending on the condition of the baby, weight gain and feeding issues, she has to come weekly or once in fortnight, but she has to frequently come for follow up so that you can monitor how the baby is doing. Next. That is why there are certain guidelines. As you know, in community we are going to have low birth weight or premature babies, but they are stable, and then they are to be taken care by the mother or anybody caretaker. He can very well do the kangaroo mother care. But once these children, facility based means it may be hospital, it may be district level or community health center or even PSCs. In all these conditions, we will be having the newborn with some or the other problem, right? So these guidelines are divided depending on the birth weight of the baby. So first, if the baby is more than 1800 gram up to 2500 gram, they are normally stable and they can be given kangaroo mother care right after the birth. Is it clear? If the baby is between 1200 grams up to 1800 grams, majority of them will have some or the other morbidity, like they may have respiratory distress, they may not be able to feed themselves, right? They need special feeding technology because they are not able to suck, swallow, and respiration may not be coordinated. So it is they are to be monitored. These babies are transferred to a specialized center for the care and best transported with the mother or family member. If transport incubator is not available in our condition, majority of the time they are not, these transport incubators are not available, and they are to be transferred with the mother or the family member, and then they are hospitalized. It may take some time, from days to some time, to before starting a KMC. Mother, if accompanying, she can be asked to provide the kangaroo mother care inside the facility also. Dr. Vandana was showing some pictures of the Shupri and all other SNCU. You must have seen one mother, she was sitting inside SNCU and she was giving kangaroo mother care. When you see the baby is still inside the facility, still inside, she is there, then still mother can go inside wearing a gown, and under direct supervision of the doctor and nurses, she can provide the kangaroo mother care. Less than 1200 grams children, they are really sick. They have very serious morbidities, and therefore birth should take place in the specialized center. The best way to transport such newborn is in utero. The mother should be shifted to a specialized center where the delivery of the baby is under the guidance of a professional doctor, and then they are shifted to the SNCU or NBSU, and they may take days to weeks before we can think of KMC can be initiated. And in these patients, ideally KMC should be initiated inside facility as soon as they become hemodynamically, means their heart, respiration, blood pressure, they are stable. Still mother can come inside and she can sit there for an hour or so, and she can provide the KMC. Next, please. As you can see in the next slide, instead this kangaroo, we are creating an artificial pouch, and then we are putting the baby inside this pouch. What are the benefits? Effective thermal control with a reduced risk of hypothermia because of skin to skin contact, decreased hypoglycemia, apnea, oxygen requirement, and infection. Mother is taking care, nobody is handling very frequently, so infection is not there. Apnea means the baby stops breathing because of immature brain. They stop breathing, and if not taken care that particular time, they may have severe depression of the respiration. Because the mother is breathing, that provides constant stimulus to the baby to maintain respiration in preterm babies. It alleviates pain in preterm, increases alertness as well as quiet sleep. When they are fed, they have a very comfortable sleep. They are all the time with the mother. It has definite role in a better weight gain. It reduces hospital stay and achieve better follow-up rates. Right? Mother is confident and they come very responsibly for the follow-up with the uh, health facilities. It facilitates physiological stability and thus fosters baby health and well-being. So it is a better physiological stability of heart, respiration, and temperature, blood pressure, and that is why they become better. Similarly, next please. Similarly, there are benefits to the mother because she is all the time with the baby. She is confident in handling the baby, and it promotes lactation and facilitates the feeding interaction. She is constantly looking at the baby. The face is so near. Even when baby is alert, he can look into the mother's eye, and both of them, they start developing bonding. It increases rate and duration of exclusive breastfeeding. It definitely decreases maternal stress. As she is outside the SNCU, she is constantly under stress. This stress suppresses lactation, and that is how it has very important impact on the breastfeeding. It empowers parents, stronger bonding, increases confidence, and there is a deep satisfaction due to active involvement in the care of the baby. She does, next please. She does not feel helpless that she can't help the baby. She is also involved in the care of the baby, so she gets a feeling of satisfaction that I am doing the best for my own child. It definitely saves money as the baby is discharged early from the hospital, and hence father can resume the duty early. We at sitting at the facility, many times we can't realize how much financial impact they have on the family. They lose their wages many times, they lose their job, and unfortunately they take lot of loan from the other rich people, and they have to repay for the whole of their life, and indirectly it has a great economic burden on the family, on the society, and finally into the on the country. They have KMC babies as they are being maintaining their respiration, temperature, and exclusive breastfeeding. They are healthy and they have better IQ because of the IQ as well as EQ, emotional quotient. Emotionally also they are more stable because they are exclusively breastfed and constantly taken care by the mother. It decreases child abuse and abandonment because the whole family is, next please, whole family is involved in the care of the baby. Obviously, if they are too much attached, you cannot abuse and abandon the baby. How to start KMC at facility? All hemodynamically stable low birth babies can be given KMC. Hemodynamically, they have good respiration. They are not requiring any assisted respiration. Their heart rate is normal. Their BP is normal. They can be put on KMC. As soon as the baby is stable, you can start KMC. It can be started right inside SNCU. You have to counsel the mother and family together. If mother is unfortunately not available for any reason, encourage father or any member of the family for kangaroo care. There is no need to have a separate room, chair, or clothes for KMC. It has to be everywhere where the mother is, or it is SNCU, or the mother is lying in a mother's ward. Any place you can start KMC. Do not designate or make a KMC ward or special chair or special clothing, because that all indirectly interfere. हम वहां तो ऐसा करते थे, how can we do it at home? That gives a negative or a specialized feeling in the mother's mind or the relative's mind that this is something special which cannot be practiced at home. So do not make it a something specialized. It can be done by anybody at every place. Next please. That is why then if you have decided you have to give KMC baby stable, you have to start the skin to skin contact immediately after birth for all babies is a must. Whether you have to shift the baby to a special unit, but as soon as the baby is delivered, you have to deliver on the abdomen of the mother, and the baby should be moved immediately and covered with a cloth. And then you assess whether this baby needs to be separated and to be transported. Then try and transport with the mother if mother can see, that mother can also accompany. Early initiation of breastfeeding, and you have to make a checklist what you are going to see, follow and watching during the when the mother is going to do the KMC. Written KMC policy should be there in the hospital. We had been, next please, we had been putting written breastfeeding policy. Similarly, we have to have a written KMC policy in the hospital so as to improve the implementation of the KMC. Implementation research for KMC have proven that pre-service training of healthcare worker is essential. Pre-service training care, if you are practicing in your hospital or in your medical college, all the students coming, all the nurses who are attending the ward, if they are seeing what is this going on, they are inquisitive and you teach them, then definitely this will start a pre-service training and that will become a part and parcel of their practices. Nurses find it is something really unfortunate. This is seen in our hospital also. They find KMC is a hindrance in their work. They have to be little more patient because they feel कि अरे अब क्या है, बच्चे को ये देना है, this we have to see and this we have to do. So nurses are to be convinced for this use. They are uncomfortable with the fathers. Uncomfortable chair and slings play important role. So mother can be sitting in the comfortable chair, or even she can be sitting in a comfortable bed, and slings may be indigenously prepared. Slings may be used to hold the baby properly. Next, please. And that is how you start in your facility. So here I have this one video. Here the doctor is trying to convince the mother. Please, if you can share the video with us.
के बारे में बताते हैं, यानी कंगारू मदर केयर या कंगारू मातृ सुरक्षा। ये खासकर उन शिशु के लिए किया जाता है जिनका जन्म का वजन 2.5 किलो से कम हो या जो समय से पहले पैदा हुए हो, यानी प्रीमेच्योर हो। इससे बच्चे को कई फायदे होते हैं। बच्चे का वजन बढ़ता है, बच्चे को गर्माहट मिलती है, बच्चे का विकास तेजी से होता है, बच्चे को संक्रमण में खतरा भी कम हो जाता है और बच्चे की अस्पताल से छुट्टी भी जल्दी हो जाती है। इसके अलावा माँ और बच्चे के बीच में लगाव बढ़ता है और माँ में स्तनपान का बढ़ावा भी मिलता है। जैसे केएमसी में कंगारू जैसे अपने बच्चे को अपनी थैली में डालकर शरीर से लगाकर रखता है, उसी तरह इसमें भी माँ को अपने बच्चे को अपनी छाती से लगाकर रखना होता है। सबसे पहले हम बताते हैं, माँ को सामने से खुलने वाला गाउन पहनना होता है और बच्चे को डायपर, टोपी और मोजे पहनकर रखना होता है। सबसे पहले इसमें माँ आरामदायक अवस्था में बैठ जाए। उसके बाद बच्चे को माँ की छाती पर लगाएं। माँ की छाती पर बच्चे को इस तरह से लगाना है जैसे बच्चा हाथ पैर फैला के मेंढक की तरह छाती पर लिपटा रहे, दोनों आंचल के बीच में। बच्चे का सर एक तरफ कर दें और इसके बाद बच्चे को ऊपर से कपड़े से ढक दें। इस तरह से बच्चे का सर एक तरफ कर दें और उसके बाद कंबल या कपड़ा लपेट दें उसके ऊपर। ऐसे बच्चे को कम से कम 1 घंटे तक रखना है। इस दौरान माँ अपने बच्चे को देख सकती है, बात कर सकती है, लोरी सुना सकती है। कुछ विशेष बातों का ध्यान रखना है। माँ को अपने बच्चे को देखते रहना है, बच्चे की सांस और धड़कन को महसूस करते रहें, बच्चे के हाथ पांव देखते रहें, नीले नहीं पड़ने चाहिए, ठंडे नहीं पड़ने चाहिए, गर्म रहने चाहिए और गुलाबी रंग के रहने चाहिए। केएमसी घर का कोई भी सदस्य करा सकता है, पापा, मम्मी, नानी, दादी। बस इसमें खासकर सफाई का ध्यान देना होता है ताकि बच्चे को कोई संक्रमण का रिस्क ना हो।
So we have a routine practice in our all postnatal wards where we have a separate Sultania Zanana hospital, and the mothers whose babies are admitted in Hamidia, they are with us, right? So we are keeping as routine, and especially during winter season, so we survive only with the Kangaroo mother care. So now I next hand over mic to Dr. Purva Goya, who will be taking care of KMC, how you are going to do it during the pandemic of COVID.
Thank you, ma'am, and thank you so much, Dr. Vanna and Sphere India, for giving us this opportunity. So I'll be sharing my screen. I'll be talking about Kangaroo mother care with the COVID-19 context, and I think there is somebody, his mic is unmuted.
Yeah, please Anil mute everyone's mic.
So what is the important issue with the KMC and breastfeeding? Also, there is lots of apprehension in the mothers, and also previously with the healthcare workers, also including us, that whether KMC is allowed or not, because this is a very contagious disease and the baby might get infected. But all the evidence since the pandemic we have now lots of evidence which says that KMC and breastfeeding has to be continued if the mother is suspect or a confirmed case of COVID-19. That means both the things are to be going on as previously as we were doing in the before the COVID era. Now we say post COVID era or pre COVID era. We have started using these words. So for us, it is now clear, very clear, and we are practicing this also, that we are not separating the mothers from their babies, and they are doing KMC along with the breastfeeding. And also there is no contraindication to immediate skin to skin contact, that is the which we do immediately after the birth, if the baby does not require any kind of resuscitation. So baby is born immediately and put over the abdomen of the baby. So this also has to be continued in a COVID positive or a suspect mother. So all other societies and also WHO, UNICEF, FOGSI, IEP, NNF, American Academy of Pediatrics, and also the KMC Foundation of India recommends KMC to be continued in all the low birth weight babies born to COVID-19 positive mothers. What important thing we have to look after is infection control, prevention control practices to be followed by mother and other caregivers. So what infection prevention control practices are to be emphasized is that the mother should be wearing a medical mask, and we should explain the mother how to wear the mask properly. Like the mask should cover the nose, the mask should cover the mouth, and it should be till up to the chin, and the mother should not remove the mask by holding it from front, and the mother should be removing it by holding the sides of the mask or the slings of the mask. So mother should be wearing a medical mask, and mother should be washing her hands with soap and water, preferably with soap and water, before and after feeding the baby, and also while doing any work related to the baby, like changing the diapers or changing the clothes. So she should be washing her hands, and she should also she can use like alcohol based sanitizer while in hospital, because many times it is not possible for the mother to go from her bed to the toilet many times. So she can use the sanitizer, but preferably washing hands is like it's preferred. And also safe disposal of the mask and the other uh, things which has used, like the tissue paper or something like that. And she should maintain physical distancing properly also, and also she should refrain meeting people who are having like cough and cold, if the mother is suspect or mother is like we think that the mother is just not having any symptoms there, like whatever we have seen till now, that many mothers who deliver their babies being COVID positive are not symptomatic. They are mainly asymptomatic of the COVID-19. So these mothers should also practice social distancing. Now, this is a pictorial depiction that when we are talking that a baby is being born, so this is delivery room, and this is a COVID-19 suspect mother or a COVID-19 positive mother. So here we are advocating, and everybody is saying that yes, skin to skin contact is to be followed, and also delayed cord clamping. Both of the things which we have been doing it in previously before the COVID era are to be followed up now also, and with complete and proper PPE should be worn by all the healthcare workers who are there in the room, and also there should be very minimal number of providers in the room. And this is for the mother, that mother should be told properly how to wash the hands, how to save disposal of the mask and everything. And also mother should be told if the mother is positive or symptomatic or like suspect, then she should be in touch with the healthcare worker with monitoring of temperature. And this will also help in uh, like diagnosing any problem in the mother. This is like KMC happening inside the SNCUs, or this is like some is a small ward which is being made where suspect mothers or other mothers are giving the kangaroo mother care to the babies. So here we will tell them to wash their hands properly, take a have a thermometer, digital thermometer at home also, and so they can properly monitor themselves and safe disposal. This is again a mother in during this COVID times. We we tell all the mothers to wear mask, and they are providing KMC. This is again a picture of our ward, where mothers are providing KMC, and this is not a suspect or a positive ward. This is normal. This is non-COVID mothers who are giving KMC, but KMC is going on in all the wards. This is a picture which is taken from net, which I just wanted to emphasize that KMC, the name is Kangaroo Mother Care, but yes, fathers can also give, and this is not this is a picture where father is also providing care to the baby. I am just starting a video in which we can see this is a video made by AIMS, and here we will be telling you how to counsel the mother or the caregiver for
Dr.
KMC.
Purva,
Yeah.
Purva, if we can make it shorter because we have to go back to Dr. Vani ma'am.
Okay, fine. So we'll I'll just run this small video, which is
we
from.
have a full KMC video in the end, Dr. Purva.
Okay, fine.
You can show this, but fast forward it. That's all my request.
So I'll just wanted to tell you, like in the COVID times, how we are doing it. This is a very small video. I will just show this.
सेटिंग में कंगारू मदर केयर कैसे करते हैं। केएमसी कराने वालों को अपनी स्वच्छता का विशेष ध्यान देना है। माँ को आईसीयू में अंदर आने से पहले कुछ विशेष बातों का ध्यान रखना है। माँ को गाउन, मास्क और हेड कैप पहनना है। तो आईसीयू में आने के बाद माँ को हाथ धोने की विधि समझाएंगे।
So this was a video where we just wanted to tell you that we'll be asking the mother to wear all these things, and then she can enter the ICU area or any area where the baby is being kept, and with proper hand washing technique. After washing the hand, the baby mother can come inside and do the KMC. So the exact position and all, I am not showing this video. We'll be doing it later. So these are some. This is just one more slide where we will be telling the COVID-19 positive neonate, if the mother is COVID-19 positive and baby is not COVID-19 positive, there. So how to take care, which I have already told you, and this is a WHO WHO picture which is being given by the WHO only, so that breastfeeding has to be continued and KMC has to be continued, so that the babies are given the benefits of breastfeeding. And recent research have also shown that breast milk is protective for novel coronavirus. This is one picture where I wanted to tell you that this is a health caregiver who is giving proper instructions to the mother and the community also about the kangaroo mother care. And this is a picture of a nursing staff who is giving KMC while working. And this is a picture of a story of an orphan baby who is being nurtured in Telangana. KMC has been done by sisters, and this baby is now around 2 years. So this is one important thing where which re-emphasizes the need for KMC, and this is being given by a nursing staff of a Telangana SNCU. And this is KMC again, where it is mother is giving KMC. caregiver is giving KMC and the baby is having endotracheal tube inside. So these are certain points where we can not not emphasize KMC, but yes, KMC can be given inside the SNCUs. And also during the COVID times, we are continuing KMC because there is no contraindication, and complete IPC, that is infection prevention and control measures, are to be followed. So that is all from my side. Thank you.
Thank you so much, Dr. Purva and Dr. Jyotsna. Both were very enlightening presentations for all of us, where you emphasized on how to give KMC at facility, how we can start the Kangaroo mother care, and not only mothers but fathers can also give Kangaroo mother care. You have also highlighted the key position, how you are counseling the mothers, how in COVID times you are managing hand hygiene and other precautions and continuing KMC at facility. Without further ado, I would like to share the screen again for Dr. Shashivani's presentation. Dr. Vani, have you joined back, Dr. Vani? Over to you, Dr. Vani, ma'am.
Thank you very much. I'm sorry for some technical errors, but now we should go ahead. I partly heard earlier speakers, they had given very good tips. Within the given time, I would like to highlight on a few points which we should know. First of all, the terminology, Kangaroo mother care, that doesn't mean only mother has to give Kangaroo care. Kangaroo care, I'll just give some of the highlights because our time is limited. So Kangaroo mother care, that is, mother is giving breast milk, and Kangaroo care has got three important components. That is holding the baby skin to skin contact on mother's chest, and then also breastfeeding, promoting as much as possible breastfeeding, and then planned early discharge and scheduled follow-up, regular follow-up. So keeping this in mind, mother's milk has a very important part of Kangaroo mother care, and breast milk only mother can give. So to give that significance to the Kangaroo care, they have conventionally accepted the term Kangaroo mother care. That doesn't mean only mother has to give the care. Father, brother, sister, anybody, or even a neighbor, anybody can give, provided it is a close skin to skin contact. Now, in our terminology, we always use the word not just mere skin to skin contact, but it is a loving embrace which the mother gives. So from that angle, we will start. We will go to our next one. Please go to the previous slide. And why we need Kangaroo care also, all of you. Yes, these are the three things we would like to promote now. That mother's chest is the best place for the newborn care. So even for sick babies also, to the level possible, you try to use mother's chest as the best place for the newborn care. Earlier, we started whenever incubator care was not available, then we do Kangaroo care. But now we go to the other level, that only when Kangaroo care on mother's chest is not possible, we use the other alternatives like warmer, incubator, and so on. So to signify that, now they have come up with the slogan that mother's chest is the best place for the newborn care. And naturally, mother's milk is the best food for the newborn. And when we are talking about Kangaroo care, it is prolonged care given mainly for the low birth weight babies, where many of them may not be able to directly suck the milk. So mother's milk, so breast milk feeding, that is why we say mother's milk is the best food. Whether the baby is able to directly breastfeed or the baby is able to be given as express breast milk, but still mother's milk is given to the baby. Even for the preterm baby also, now we want to promote mother's milk. So that is the one addition we want to make. And zero separation of mother and her baby as much as possible. So we will discuss about this thing, and other speakers have also mentioned that kangaroo care should not be considered something different, something special only for the low birth weight babies. It can be given to all the babies, and it should become a part of the routine care of the newborns. Now, when you give for the term babies, these term babies also do get some benefits, but they will live as early as possible. So prolonged kangaroo care will not be given, but the direct skin to skin contact or the mother's embrace is given to all the term babies also soon after birth. And that is what we are saying by early skin to skin contact for all the babies in the delivery room. Only those babies who require immediate resuscitation or any other life-saving intervention, they have to be obligatorily separated out, or even some of those procedures also can be done on mother's chest. Now, why we are insisting on this? By giving this early skin to skin contact, there are certain advantages. First of all, the physiological stability of the baby is achieved faster. That is, respiration, heart rate, they all stabilize faster so that the baby is ready for feeding. By keeping the baby on mother's chest, mother's hormonal stimulation occurs, and that helps for proper breast milk secretion, and that also helps for the baby's growth. Third thing is, of course, it prevents hypothermia. As soon as the baby is born, baby is wet, and immediately you have to dry up the baby. That was our earlier thing. But now we are saying first put the baby on mother's lower abdomen, because as the baby is born, and nowadays we are also recommending delayed cord cutting. So as long as the cord is not cut, immediately shifting the baby to mother's chest may not be possible. So in that case, first you put the baby on mother's thighs or mother's abdomen so that you are maintaining the skin to skin contact, and then immediately after cutting the cord, not immediate cord cutting as per your protocol, but soon after cutting the cord, immediately just mop up the baby dry and immediately shift to mother's chest. So that is what we are saying about the early skin to skin contact. So the advantages here is early physiological stability of the baby, early initiation of the breast milk and promotion of breast milk secretion, preventing hypothermia, and early bonding, which is helpful for the baby's brain development also. So whether the baby is term baby or preterm baby, early skin to skin contact you can give to all the babies. But by itself, it is not to be labeled as kangaroo mother care. Only if the kangaroo skin to skin contact is continued for at least 1 hour, and nowadays they are recommending even for 2 hours. In that case only you can call it as kangaroo care. Otherwise it is a simple early skin to skin contact. I hope I am making myself very clear, not confusing you. So we are talking about soon after birth, putting the baby on mother's touch. So that touch immediately before cutting the cord, it is on mother's abdomen, and soon after the cutting the cord, then you shift to the chest in between her breast, which is the position for the kangaroo mother care. So I have explained you about the kangaroo mother care, and I have explained you about the early skin to skin contact. Next. And this zero separation of mother and her baby, why they are important? By separating the baby and mother, baby is under stress, mother is also under stress, and all this stress to some extent, the full-term babies or even late preterm babies are able to cope up with. But the very preterm babies or very low birth weight babies, even that stress is also harmful for their long-term brain development. So now the evidences are coming up. So that is why this early skin to skin contact and zero separation we are insisting. Now, third point we have already said, why we need kangaroo mother care. All of you have already known that India has got the world records. Highest number of births, highest number of neonatal deaths, highest number of low birth weight babies and preterm babies, and all that they require special care under the supervision of doctors and nurses, which is very ideal. But we do not have that facility, and to that level, then the next best thing we have said, involve the family members. So family-centered care, involving the family participatory care, involve them. And to what level you can involve them? You can involve them for promoting breastfeeding, you can involve them for promoting kangaroo mother care, hand washing, and avoiding all the harmful local traditional practices which are going on. And that also helps in promoting the better care of the newborns. So that is the one. So why we want to promote kangaroo care? We have got too many small babies and preterm babies who require care ideally directly under the supervision of doctors and nurses. But that ideal situation is not available to us. So the next best alternative we have is to involve the family members, community health workers, and all the community organizations who can help us. And they can help us in promoting simple interventions like kangaroo care, breastfeeding, hand washing, and even in the COVID era also, they can help in non-separation of the mother and baby and continued breastfeeding and continued kangaroo care. So that is why we are taking the help of all the community agencies to promote these messages. Yes. Now the common causes of neonatal mortality we have found is preterm babies leading to complications. And preterm sometimes in our country involve even the low birth weight baby who can be mature, but still they may be having very low birth weight, and because of that they are handicapped. So low birth weight babies, that is babies less than 2,500 gram babies, they are likely to have many complications. So preterm babies and sepsis, which is another almost totally avoidable cause of neonatal death. So these two cause the major chunk of our neonatal mortality, and in this even common people can help us in preventing a lot of morbidity and mortality. And that is what we want to know the causes here. Next. So I have already told you about the importance of the simple interventions which even the global experts have agreed. So breastfeeding, kangaroo mother care, hand washing. Next. Next. And this same thing has been borne out by a lot of evidences also. So breastfeeding has got the highest evidence for serving the babies, and kangaroo care. Same thing. Next. I'll skip over these things. And history also, all of you know. Next, we will go. Progress is there. Now we have learned all the impacts of kangaroo care can be achieved, or even the simple interventions like breastfeeding can be achieved, provided at least 90% of the population which is eligible for receiving that is achieved. And you see our thing. We have barely reached now. This is a little older slide. So KMC has been given only for 18% at that time. And the recent data says 38. And we want to reach up to minimum of 90% coverage. So how much work we have to do? And in that, we are seeking the help of all the NGOs, all the voluntary organizations to help us promote these messages of simple breastfeeding, kangaroo care, hand washing, and avoiding harmful traditional practices. Next. So state-wise also you will see the differences, and each state can decide, and there are a lot of lacunae here, and the standard of record keeping is also not very good. So all those aspects have to be done, and this is the target we have kept. By 2030, we want to reach 90%. By 2020, we should have reached 50% coverage of KMC. But our current KMC coverage, even with the diluted definitions, we have barely reached up to 38%. This slide is pre-COVID era, but now it has even gone much lesser than that. But at the most, we had touched 38% coverage, but after COVID, it has again gone back. We do not have the latest figure. All that we want to impress upon you is lot of work needs to be done. Next. And lot of advocacy needs to be done. Now, keeping this position also, I will cover it here. Okay, this origin, all of you know, it started in South America. Next. And because it was similar to the baby kangaroo being in mother's pouch, it was called kangaroo care. And direct skin-to-skin contact, warmth, breastfeeding, and zero separation of mother and baby. All these are important aspects of kangaroo care. Next. Next. And many times when, please go to the previous slide. Many times in the community level, when we want to talk to the people or when we want to train our community workers, many of them have not seen what is kangaroo. So the concept a little difficult for them to reach. But if we tell them about an example of a monkey carrying the baby monkey, immediately they get the feel. They know the position also, how the baby has to be kept prone on mother's chest, and then mother's milk also to be continued. And even during transport also, mother can carry the baby in kangaroo care. So this is just a simple, useful tip for you to educate the masses and educate the health workers in the community about the kangaroo mother care. To keep up with the convention of the international one, we retain the term kangaroo mother care, but it is something simple like a baby monkey attached to its mother. Next. Sorry, I'm skipping some of the things. So definition, all of you already know. It's a human, low-cost method, but high impact and high skill method. The moment we say low cost, people think it is only for the poor people. And even the doctors also do not give much attention. But once you know by experience that it has a high impact and it has a high skill method, then you will give more attention and pay more attention for training also, awareness also. Just because it is low cost doesn't mean no training is required. So that part also you have to remember. Next. So definition, all of you know how to keep the baby on mother's chest, I already told you, without any layers of clothing in between, and then baby is covered from above. And we would like to describe it as a loving body hug between mother and the baby. Next. Now, as I told you, it can be given to all the babies, but the preterm and low birth weight babies, they accept it for a long time and they get many other benefits. Term babies also do get some benefit. And this aspect I want to emphasize in this group here, because many of you might be working in very remote areas. And in remote areas, many times weighing scale may not be available, or the workers may not be able to differentiate who is a preterm baby, who is a low birth weight baby, and so on. So, and many times mothers also feel, why one baby is being given on kangaroo care, why not the other baby? All this we have faced in our experience when doing the community newborn care. So then we have come to one conclusion. Full term or preterm baby, all babies can be started on kangaroo care in the peripheral setup. In the hospital setup, the questions are different. In hospital, you have to admit the patient. Naturally, that many beds are not available and not required. So we say at least babies less than 2,000 grams should not go without kangaroo care as an indoor patient and then continue at home. But in community setup, where the distinction between a full-term baby and preterm baby or a low birth weight baby may not be possible, it is easier to start for all the babies skin to skin contact. And those babies who are term babies, naturally they will leave the mother soon, within a day or two. Those babies who are preterm or low birth weight babies, they will continue to hold on the mother and get all the benefits. So that is one point we remember. Next. So better term is to use loving hug, and it is borne out by many evidences now. Next. Next. And remember here, all the benefits of kangaroo care are achieved much longer if it is given as long as possible in 24 hours. And kangaroo care is started within 10 days of birth. So all that we have to remember. Please go ahead. Early skin to skin contact I have already explained. So all the babies have to be given. Next. And kangaroo care, as I already told you, it has got three major components. Holding the baby on mother's chest, only that many people think as kangaroo care. No, it is just one part of kangaroo care. It should be combined with kangaroo nutrition, that is exclusive and early breast milk feeding as much as possible. And I told you breast milk feeding because many babies may not be able to take direct breastfeeding. In that case, express breast milk will have to be given. And kangaroo babies, those who are being given in the hospital, they must have a planned discharge. That is where our earlier speakers have also told you, you must have a proper policy in the hospital. And if baby is gaining weight satisfactorily, baby is able to take oral feeds either as direct feeding or express milk, and the baby is not having any other complications, and the mother is confident that she will be able to continue the same type of care which was told to her in the hospital, and then family members are also willing to give you support to the mother. Under all these circumstances, you can discharge the baby even if the baby has not achieved the weight of 2,500 grams. Ideally, weight for discharge will be 2,500 grams. But in our setup, majority of the babies would not stay for that long. So the next best is to have certain set criteria in your department and then decide for the discharge. And that is known as planned early discharge. Now, what is happening in our country? Because government is giving many incentives, so these are the components: kangaroo position, kangaroo nutrition, and kangaroo discharge. And at discharge, I would like to explain one more thing. Nowadays, institutional delivery rate has increased because of several incentives which the government is giving, including the cash incentives. But once they come and have the delivery, many mothers would like to go home immediately. They do not like to stay in the hospital even for the obligatory 48 hours to make sure that the baby is not having any other problem, baby is able to take breastfeeding well, and mother has learned the technique. For this, we expect them to stay in the hospital for at least 48 hours. But for their own personal reasons, and many times even the hospital staff also, they have to allow them to go home, and that is known as random discharge. Whereas if they go by certain fixed criteria, and then family members also assure you to give all the support to the mother, then it is known as planned discharge. And that planned discharge is early discharge, which is a part of kangaroo care. So major components: kangaroo position, kangaroo nutrition, and kangaroo discharge. Next. And it should be combined with regular scheduled follow-up. Either it can be had in the hospitals or it can be arranged at home with the help of community health workers like ASHAs. And then even at home also, she has to continue breastfeeding, kangaroo care. Now, many people ask how long she has to continue kangaroo care at home. See, we don't have to decide. The baby automatically decides. Around the age of 40 weeks of post-menstrual age, which is calculated from the last menstrual period if it is available, or if the baby reaches the weight of around 2,500 grams, the baby will not stay in the kangaroo care for a long time anymore. It will start fussing about or start crying or wriggling about every time the mother tries to put the baby on mother's chest. And that is the indication that the baby does not require any continued kangaroo care any further. So that is the end point. But many times, during a cold weather or just before sleep or soon after birth, the baby might like to have a good cuddle with the mother. So that can be continued. But as I said, kangaroo care in one session has to be continued for minimum of 1 hour. And incidentally, here itself, I will explain you why we insist on that minimum 1 hour. Once you put the baby on mother's chest, the baby goes for a good sleep. And during that sleep, the baby gets a quiet, calm, stressful, without any stress, good sleep. And that sleep helps for the development of the brain through multiple sensorial stimulations and many other mechanisms. And to achieve this, mother must have at least the baby must have one good cycle of sleep. And to achieve that one good cycle of sleep, 1 hour is required. And for achieving that effective 1 hour, we always advise 1.5 hours. If we say 1.5 hours, by the time mother's chest and baby, mother adjusts herself and the baby adjusts herself and then goes to sleep, some few minutes are passed. And if you say 1.5 hours, minimum of 1 hour effective is achieved so that the baby gets good sleep, and during that sleep the brain development happens. And to keep all these things in mind, in practical purposes, we tell them 1.5 hours so that minimum of 1 good hour is achieved. So the baby decides when to stop kangaroo care, but generally it is around 40 weeks of gestation or postmenstrual period, or around 2,500 grams of weight. And family should be able to give support. So all these together form the components of KMC. Now, next slide. And to achieve a good kangaroo care, it has to be started as early as possible, as frequently as possible, and as long as possible. So in the hospital, we should be able to provide a home-like atmosphere to the mother so that she is comfortable and she is calm, not agitated, and she is willing to stay in the hospital as long as we can train her well. And for that, the staff behavior also has to be courteous to her, and they should be able to talk to her in the way she would like to her. And then we should also provide facilities for her personal needs, like good toilet, running water facility, even hand washing facility, facility to receive visitors, facility for food. Only then they will be willing to stay in the hospital. And when they go home, a lot of counseling is required, not only for the mother, but even for the family members, so that they are willing to help as alternate kangaroo care providers. They help the mother for the daily chores at home, and they also help the mother for regular follow-up, either to bring her to the hospital for regular assessment of growth, breastfeeding, immunization, and also special assessment for neurological development, and even eye checkup in case of premature babies, hearing checkup for the low birth weight babies, and all these special checkup also. So all that has to be given in a supportive environment to the mother, both in the hospital, at home. So that we should be able to provide, and to achieve that, a lot of counseling is required for the family members, and a lot of training and counseling is required for the workers, healthcare workers, both in the hospital and those in the community. So a lot of things have to be done. The workers should not do it because they have to do it. They should feel involved to do it, and they should do it. We just now saw one example. The nurse was so convinced that even for an orphan baby, she was willing to give kangaroo care herself. So to that level, the motivation should be there, and that will come only with proper counseling and proper training. If good training is there, naturally their confidence is more and they will be able to do it. The duration of kangaroo care in each session, I already told you. And in each session, minimum of 1.5 hours we are saying, but maximum depending on the convenience of the mother, she can go on for 4 hours, 5 hours also. Then she can have a break. During that break, if some other person is available, they can give the baby to other person to continue kangaroo care. Or after a small break, she can again continue kangaroo care. So within 24 hours, all the sessions together, how many they had, cumulatively they will give you an idea about the total duration of kangaroo care given to the baby. And ideally, we will expect them to have at least for 20 to 24, 22 hours in 24 hours. Next. Sleep cycle also I have explained. Please let us go. And types of KMC, either it could be intermittent or it could be continuous. Intermittent wherever the in between the 2 sessions of KMC, the interval is long. And continuous if the in between the breaks are short or no breaks at all, it could be continuous. Next. So continuous for the stable babies you can give, and there the wards. Now kangaroo wards, wherever possible, they help because the mothers can talk to each other, the peer group can have a support, they can be entertained also, they can play some games, and some health education sessions can be there. At home, it may not be possible. In that case, we can, but if good counseling is given, home care can be done even by a single mother also. Next. Intermittent care can be done in the SNCUs also, along with the warmer, and next to that for a few hours also if the mother gives, that is helpful to the baby. So kangaroo care, as long as possible, it is much more helpful. But in case of sick babies or very low birth weight babies, even if short-term KMC is given for few sessions, even that has got a lot of benefit to the baby. Next. And discharge, I have already told you discharge criteria from the hospital. It is planned early discharge in most of the cases, where the baby has achieved at least satisfactory weight gain of 15 gram per kilogram body weight for consecutive 3 days, no other major problems, and baby is able to take oral feeds, baby is able to maintain its body heat without any additional aids, and then mother is confident that she will be able to continue this care at home and family members are supportive. But in the community, once they go back home, they are expected to continue kangaroo care and stop only when the baby decides to leave the mother and does not stay anymore in the kangaroo. Next. So all that I have already explained to you. If I have time, I will go ahead for the next 2-3 minutes. Do I have
2
time?
minutes more and then we'll wind up to give to the next speaker.
Okay, then should I go for 2 minutes or no?
2 minutes more. Yes, ma'am. Please.
Okay, please go for the next one. Next one, please. So kangaroo care scope. Now it is, earlier we started with stable babies, but now we are giving even to the sick babies. In a smaller center, the babies who are stabilized, who continue on IV fluids, continue on minimal oxygen, or they are in the nasogastric feeding, they can be given kangaroo care. In a tertiary care center, even for the sick babies also, even those who are on the CPAP, those who are on the mechanical ventilation, there also now people have started giving kangaroo care. It can be given to the babies who are delivered by cesarean also. Here you can see. Cesarean has become one of the commonest excuse to delay breastfeeding and delay kangaroo care. But if mother is otherwise stable and if some attendant is available, we can give breastfeeding also immediately and continue skin to skin contact. Only difference is instead of keeping the mother in the vertical position in between mother's breast, you can keep the baby on a horizontally. So that skin to skin care is achieved and till the mother is ready for the usual vertical position. Next. Twins also can be given breastfeeding also and kangaroo care also. Next. And triplets and all family members can help. Here the father is helping, grandmother is helping, triplets are there. Next. And then promotion of home-based KMC. As I said, it is very important now. And for that, you have to prepare the workers first, train them well, orient them well, counsel them well, motivate them well. And then combine with a lot of women's group meetings so that whenever the worker is able to advise them, they cooperate with her and accept it. So a lot of counseling, lot of meeting, lot of preparations are required. And in this matter, the various voluntary healthcare agencies who are working all over India, in tribal areas, in urban slums, in remote rural areas, they can help us. They can spread these messages by conducting the women's group meetings. They can be a link between the worker and the family, and they can help to prepare the community to accept the kangaroo care. Then they can prepare the community to make it as a part of habit in the community there and continue there. Even in the remote areas nowadays, we find even the male folk, fathers are also able to give kangaroo care. And such slings if we have, that is helpful for the safety of the babies. It's not very expensive and we can provide. At the same time, of course, as the first speaker said, it is not necessary that only if some special chair is there or some special cloth is there, kangaroo care is possible. Kangaroo care is possible without any of these things, but if some additional help is given, it helps for prolonged kangaroo care and safety of the baby. Next. See, here I have one story to begin with. A 600-gram baby born in an SNCU, born in a hospital, but because it was 600 gram, the doctor thought it's not going to live. So he just told the nurse who conducted the delivery, ask the parents to take the baby to higher center, and if they are not in a position, let them go back home because here we cannot do anything for the baby. Now that baby went home because they could not go to higher centers because of several other reasons. And because of that, our worker who was trained and who was motivated, she visited this family within about 4 hours once they reached home. She trained them. Mother and mother-in-law did kangaroo care and this baby is doing fine. Today the baby is 9-year-old and I have the picture. She is doing very well in the school. Similarly, now I have got several case reports of babies less than 1000 gram, babies less than 1200 gram. Here is a set of twins born to farm laborers. Even if the hospital was close by due to their personal reasons, they could not go. So at home, father and mother alternatively, they gave the KMC. Today, these babies are almost 5-6 year old. Like that, we have got now so many examples. Baby is delivered on the rickshaw, baby is delivered on the way, and they could not go to a hospital. And then workers advise them for kangaroo care. And God willing, they are doing very well and good day. So there is a lot of scope for the community-based kangaroo care. Community-based kangaroo care can be given under 3 circumstances. Those who had delivered in the hospital, started kangaroo care in the hospital, had a planned discharge as per the policy, and then continued care at home. Second group is those who are born in the hospital but could not stay in the hospital. They just went home, but the baby was low birth weight or a preterm baby. Then the health workers advise them, and the babies are doing well. And third group is home delivered and home cared for. So all these babies, there is a lot of scope for home-based kangaroo mother care. And we can give kangaroo mother care even during transport. During transport, people used to advise even the transport incubators with the facility of oxygen, ventilator, and so on. But everywhere we cannot get that. So the next best thing is carry the baby in kangaroo position. Ideally, will be with the mother, but if she is not there, even the family members, whoever are taking the baby to the hospital for some reason, they can also carry the baby in kangaroo care. And they can give the baby mother's milk express and also. And these babies who are very sick also can be given kangaroo care. Now, babies in the hospital, they have so many painful procedures given to the baby. Blood is taken for investigation, intravenous fluids are being given, oxygen is being given. In all these situations, the baby undergoes several pain. But if the baby is put on kangaroo care and then given the break or then given the vaccine, the baby feels the pain much less. It is reflected by less cry and baby going to comfortable sleep. So even as a pain relieving measure also this can be given. Now there is another component. Now a lot of places they have started breast milk banks. Now in this breast milk bank, mainly the preterm babies, their mothers, they can give their surplus milk. Like that, there are so many scope is there. And I think I will stop it here and then we will take up some questions. Thank you very much.
Thank you so much, Dr. Vani ma'am. Requesting you to please stay back till the end because we'll be taking the question answers after all the panelists have spoken, ma'am. And it has been so enlightening always to hear from you, Kangaroo Mother Care, because you go into the little nuances of care with your experiences and how Kangaroo Mother Care can be done anywhere by anyone, provided they are healthy and they are taught and counseled on how to do kangaroo mother care, and we can save so many newborn babies. So with that, ma'am, I will hand over to the next speaker, and I would like to introduce the next speaker. The next speaker is Dr. Alpana Moidi. She is one of the nursing mentors at West Bengal, and she is really experienced in terms of providing kangaroo mother care in West Bengal, and also not only providing it at facility but also training facility and community workers. She is a professor at the Government College of Nursing, BSMNC, West Bengal. She is a MSc in Pediatric Nursing and PhD in Nursing in the field of Neonatology from West Bengal University of Health Sciences. She is working closely with newborns since 2015 and providing and teaching KMC and training in DAS2 DASI, and has presented paper and delivered speech in the neonatal forums. So over to you, Alpana Maidi. Welcome to the forum, ma'am. And we look forward to hearing from you the role of nursing, ma'am, in kangaroo mother care, and how you have been successful, and what are your experiences with the nurses who can give kangaroo mother care. Ma'am, would you like to share your screen or presentation, ma'am?
Am I audible?
Yes, ma'am.
Oh, am I audible?
Yes, ma'am, you're audible, ma'am. Please go ahead.
Okay. Good afternoon to all. Care is a humanized, cost-effective newborn care and has been described as primarily a nursing intervention with medical support. Nurses play a key role in providing appropriate care at a time infants are more vulnerable and families are struggling to make sense of what has happened. She can be a role model, caring ethos and personal qualities. Ma'am, please. Hello, ma'am, please share.
Yeah,
Hello.
Can Anil share
Ma'am,
Alpana
please
ji? We
share
have
my.
not, ma'am, we have
হ্যাঁ
not,
হ্যাঁ আমার
we have not
I have
received your
seen
slide, ma'am.
sent it in Dr. That previous mail, no? I have already sent. Hello. Dr.
Hello, ma'am.
Mail.
Ma'am, you, ma'am,
Yes.
just give me a second, ma'am. Anil ji,
I
can
have
you please
mailed it
share the
earlier.
slide? Yes, please share it with me, ma'am. You can start speaking in the meanwhile, ma'am.
Okay, I can continue. There are several roles of nurses. First, nurse can be a counselor and motivator. Counseling has already discussed, but till I can say counseling session can be started as early as possible so that mother's force increases to initiate kangaroo mother care. Proper and ongoing counseling continued when needed. Barriers of kangaroo mother care implementation to be identified and possible remedial measures must be taken. Successful KMC mothers will be involved for counseling as mother. Here I can give one example. Initially, I was for long back when I was practicing mother care. Once mother was not motivating at all for to motivate her. I talked to her husband and everything. When at that time KMC and she came with her baby, and I asked her to his mother. And when this mother give the example and her is increasing the weight and everything, at that time this mother was so motivated and she continued KMC. After that, I used the mother who works in KMC as a for motivating the other mothers. The mothers are the best motivator of kangaroo mother care. The prime important task of the nurse is to motivate the mother as father and close family members. And nurse care provider for securing the infant safety, she should ensure the correct practice of KMC along with basis of infection prevention. First, we have to give theoretical knowledge of the mother, means what are the benefits of care and how to put KMC. Already it has been discussed. And then baby should be, mother should be demonstrated kangaroo mother care, and we have to stay beside the mother and give baby on mother's skin to skin contact, and we have to give support to the mother, staying with the mother and ask the mother whether mother is any difficulties or not. And before putting the baby on mother's skin to contact, we have to prepare the mother as well as the baby. We have to say whether baby has soil or not, and if any feeding anything is required the baby, that when baby have to put the cap and socks, and then have to open the front open dress. We have to provide to the mother, and we have to give the mother in comfortable position, and then we should give the baby to the KMC position. And when baby is too small, so sometimes mother is very much of taking the baby. So we have to stay with the mother, and we have to support the mother that I am here, so you will not face any problem, and to give support, then touching the baby and asking the mother, see the color change of the baby, and mothers also become very much means satisfied with this session. And after that, once I asked to the mother, after putting the baby in KMC position, 10 to 15 minutes, I asked the mother, how are you feeling? Then mother say, I'm feeling so happy, so feelings I cannot express you. This baby like my own baby. I asked, this is your own baby? No, I was not taking the baby. Now I am feeling so happy, so I cannot leave the baby now. This way the mother's satisfaction also come, and we can ask them to continue the KMC. As long as initial stage, we will start with a short session, and then we can continue the next continue the KMC in location. Next, as a nurse, we have to support the mother, that already I have told, and we have to give support to the family members also. Sometimes mothers can have some problem with the means she cannot discuss everything with the healthcare providers, healthcare providers, doctors, or cannot communicate family members. And at that time, nurse is the person who can give support to the mother and communicate with the family members for special information, and convey the mothers uh, what mothers want to say to the doctor, that the nurse can convey that portion to the doctor. And as a nurse can do advocacy. She can do advocacy to the mother, family members, as well as hospital administrator. Some hospital administrator are reluctant regarding the kangaroo mother. So nurse can do advocacy to the hospital administrator for regarding the facilities of kangaroo mother care, what required, what things required, such as the kangaroo chair and like that. That nurse can do the advocacy to the hospital administrator. Actually, in the initial stage, when I started my kangaroo mother care, that is in 2005-6, that time we don't much facilities in the unit, and only within the NICU, putting a chair and giving comfort, provide care to the mother. And after that, we have purchased the kangaroo, and our facility has improved, and now we have kangaroo ward, and ward also established in different district hospital, medical college of West Bengal also. So we have to do advocacy to the administrator, so that we emphasize the kangaroo mother care. We also can advocacy to the other members and other deliveries, other members of the healthcare delivery system. We can advocate to the community leader. The community leader, whenever mother will return to the home, or while we provide kangaroo care to the home, or in the sub-center level, or in primary health center level, there the involvement of the community leader is very important. So we need to advocate them. If they are motivated and know what is kangaroo care, what is the benefits of kangaroo mother care, the we can implement in the periphery level. That also we are trying, and we are doing in the periphery level kangaroo mother care. In sub center also, I have once in a district, in a block primary health center, in a block, I teaches the ANM and ASHA worker also, and they are very they are practicing kangaroo mother care in the home, and they're very means interested to do kangaroo mother care, and they come through the whole means procedure practice. So in community leader, we can involve to advocate to the community so that they can get support, and other stakeholder of the kangaroo mother care. As a teacher or as a trainer, a nurse can explain the concept and facts of kangaroo mother care, and demonstrate the procedure and enforce the learning to the periphery level worker in and frontline worker. She can organize and conduct program. What I told, that I have organized and conducted so many training program for the ANM and frontline worker, for in-services and pre-service nurses, that is the under means outgoing student, that general nursing midwife student, BSc and master student. I conducted training for them, and even for the PG student of means doctors, conducted training for them also. And in service training, when newly staff is posted, we have to give training to them, otherwise they will not be interested. And here I can share one experience. When I was starting kangaroo mother care in 2005-6. That time I was doing kangaroo mother. Other staff, they were not so much interested, and they were helping and they ask to the mother when I will go, and then I can do the kangaroo mother. After few months, when I teach them, I involve them in the, and after that, they also are involved in kangaroo mother care. And now the season is that the kangaroo mother care responsibility is everybody's, and who is there in even in the labor room or in places, everybody are practicing kangaroo mother care. So after so many program, different phases, and then only it has been possible. In Bengal, we are conducting different phases training program, even for the different facility, means the SNCU of the different district. And this usually conduct the doctor, nurses, everybody in together, and so different facilities. And now they are also practicing kangaroo mother care very nicely. And as a resource person, nurse is a good resource person, since should know everything. Where whenever mother who is practicing KMC, mother will go to home after discharge, and she have to continue KMC at home. So if any problem, anything is required, the nurse will give the answer, give the all information. Suppose the mother is in remote village, so nurse should inform to the community health nurse that area or particular that district, and so that if any problem this face, then the mother can get help of that community health nurse, and she can, when mother will be discharged, she can go home and visit the mother, problem mother is having, and she can help the mother. And nurse have to identify any other risks and challenges and problems to implement and implement the feasible solution to prevent or overcome the obstacle. What problems mother will face? If mother is having any problem while we are providing kangaroo mother care, that time we will inquire who will in the family will resist this procedure. We can help that means other support person, we can identify that, so that mother can get help of that person. If anybody is there that can resist, so we can communicate that person and can make her easy, asking to the husband of that mother, and he can motivate that person before mother going to home. Uh, Once I had a problem, one mother was practicing KMC in the hospital, and it was so nice. She was practicing, and that baby was 100 gram, and when baby was 100 gram, then mother was planned to discharge, and mother went to home, and both parents were very means aware regarding the kangaroo mother care. And after returning, when next day aware, then mother was crying. I asked what has happened. Then mother told, my mother-in-law is not allowing to practice KMC. Then I to the husband and call everybody to come to the hospital. Then I counsel that mother-in-law, and again she was means so many after long discussion. Then she agree, and they return to home. After that, they continued KMC successfully. We have to identify that barrier person before discharge only. That I didn't ask, that's why it has problem. But before discharge, we have to identify that racist person, and we have to motivate that person. How to motivate that? We have to the way. And again, my nurse is a communicator. Already I have mentioned that nurse can communicate with the mother and the doctor, mother and her family member. The nurse can maintain the liaison. Once I faced one time, the one mother was not getting, means family members was not coming and giving her the sufficient extra foods and like that. Was morose regarding that. Then I talked to the husband that this is for her, that she is staying in the hospital. Then the problem was solved. So this small problem that only nurse can identify and can, because nurse is continuous with the mother and she is there, and mother is very free to communicate to the nurses and say everything to the nurses, so we can communicate to the we can continue to the mother way. And nurse can also act as a behavioral change communication BCC to change the behavior of the other personnel to promote kangaroo mother care and communicate with voluntary organization so that kangaroo care can be continued and placed in a skilled basis. And in conclusion, I can nurse is the right person to advocate humanized approach to help in the survival of tiny neonates. The dynamic role of the nurses is important in the support for KMC in a multidisciplinary team. The nurse's role is one of the skilled expert, trainer, advocate, care provider, and provider of emotional support and guidance to mother and parents. Can share one case. One mother, she was delivered a baby that was 1,000 gram, and she was not eager to do care. I motivated her, and she continued KMC, and she was discharged. Even she come forward, follow up, and follow up. The baby was well and everything, and at 1 year when I have done her developmental assessment by DASI scale, and it was very good in motor and mental development also. Mother, again, this mother having second delivery at 2.5 years later, mother delivered second issue that also low birth weight, and that time also mother is very good, and she started kangaroo mother care, and this baby was okay, and baby was discharged. And after that, after 3-4 years later, once I enter into the ward, and again I coming out for some work, and somebody was calling me, and I have that same mother is lying in the bed, and she has had again one preterm baby, and she is for KMC, she is in the KMC ward, and she was seeing me, she was so happy, just like we are meeting our close relative long back. She was talking so many things and told that her father, whom she was, that daughter is now older, and she is going to school, and she is doing very well in the school. Performance is very good, and this mother is telling to other mothers also, only for kangaroo mother care. And she's so happy. I told that she has discussed in the school of that girl also. That girl is so good in behavior and everything, that is due to kangaroo mother care. So this is one example of kangaroo mother care. But that three babies are preterm, and mother continues kangaroo mother. She is a good motivator of kangaroo mother care. She usually motivates her village and other places regarding kangaroo mother care, and asks them to do kangaroo mother care. Even those who are not low birth weight, told that if you do kangaroo mother care, breast milk will be very good and able to feed your baby breastfeeding. So she is motivated like that. Okay, can I get time?
Ma'am, yes, 1 minute more you can take, because of course we understand there was some time in the presentation to be put up. Please take 1 minute. Yes, ma'am, please carry on.
Okay, regarding support of the mother, one mother, she is a doctor, renowned doctor, and she is pediatrician, both are pediatrician, and she was having so many complications, and she once she delivered a twin baby, and both were 1,040 gram and one 1,050 gram. And she was so mentally morose, she was not coming to see the babies. And I went to ward, and she is known to me and everybody in the department, and I request her, I call her, you come and you can see your baby, and you come. And then I take her to the unit, and seeing the baby, she was mentally upset and like that. And that time we don't separate KMC ward or KMC area. I put her at there, I assure her, And after that, next day, I moved her for Kangaroo Mother Care, and I have given separate owner of the area and just like a partition like that. And I asked to all doctors, because them is not required, you don't enter that room. And I doctor that mother, and she you do KMC, nobody will enter that room. And after that,
Ma'am, we can't hear you, Dr. Alpana Moiti. We can't hear you. Okay. Probably we are having a very low bandwidth and connection with Dr. Alpana Moiti. Thank you so much, ma'am, for sharing the important role of the nurses and how you have been successful in motivating so many parents to provide Kangaroo Mother Care, and not only the parents but their in-laws and family members. So this is a very important insight that ma'am has given us on the role of nursing, not only in training the community but also training the frontline workers and continuously counseling and motivating them. Thank you so much, ma'am. We move on to the next speakers. I would like to welcome Dr. Sameer Bansode, the District RCH Officer in Gadchiroli, Maharashtra, who is an allopathic doctor with MBBS. He has more than 10 years of experience in public health programs in TB, HIV, and he has also worked as the District Program Officer in DAPCU at Thane. He has also worked with Maharashtra State Control Society. He is working with 7 years since last 7 years in Gadchiroli, and has conducted many interventions related to maternal child health in the field. He is also managing all the RCH activities in the district. The other panelist from Gadchiroli is Dr. Ashwini Mahajan, who is the health and nutrition consultant with UNICEF. She is an Ayurvedic doctor with masters in public health from Tata Institute of Social Sciences. She is a committed public health professional with over 5 years of experience and working in preventive, promotive, and curative health services in remote tribal areas of central India, especially in women and child care in Maharashtra, Chhattisgarh, and Orissa. So I would like to welcome both of you to share your experience at Gadchiroli and how you have been implementing Kangaroo Mother Care, what challenges you have faced, and how you are trying to overcome them with the community members. Over to you, Dr. Ashwini, to share your screen, please.
Thank you so much, ma'am. I will start my presentation. Actually, first, I would like to thank all the SPEAR team and you for this opportunity. We are really humbled to present in among such expert panelists.
Ashwini, you'll have to be loud and come near to the mic, please.
Sure, ma'am. I'll try my best. I just thanked everyone for this opportunity, and I'm presenting on behalf of my district public health department, Zilla Parishad Gadchiroli, for the whole team. And we are really humbled to share our experiences in this forum. We have been trying to implement home-based KMC for last 1.5 years, and we are just presenting what efforts we have done in the our community. So I would just like to present the context here about the Gadchiroli district. As you could see, it is in the far east corner of Maharashtra state, with borders sharing borders with Chhattisgarh and Telangana. It has a major forest area, 78% forest cover. It's third largest in the state. Uh, it's all tribal blocks, 12 blocks we have here, and all are tribal blocks. It is unfortunately more known for left-wing extremism. The population density is less. The district is endemic for malaria. Also, we have high IMR, MMR. So we have been, district has been able to achieve a decline in IMR. So around 2014-15, it was around 35.9, and last year it was 23.4. So decline has been there, but we are still struggling to improve the scenario. Gadchiroli has higher percentage of low birth weight. So it has ranged from 26% to 32%. Currently up to October, it is 32%, and which is highest in the state. We are trying to do some measures to reduce this, but this is the current scenario. Also, there are multiple vulnerabilities like poor mobile network, transport facilities are there. The overall healthcare access has many challenges. So we have more than total population more than 10 lakhs, birth rate is 15. So if you could see in the map here, so Gadchiroli is at the one center, most northern part of Gadchiroli, and then there are 4 5 blocks which are more backward. They face many issues regarding health services. So block Kurkheda, Aheri, Korchiar with high percentage of low birth weight, child malnutrition is also prevalent. Also, we have high numbers of home deliveries. So blocks like Etapalli and Bhamragad with percentage of home delivery ranging 32 to 34% are still there. So overall, we are at 4%, 4 to 5% home deliveries, but few blocks have higher numbers of home deliveries, which we are trying to address for a long time. Um, for sharing the home-based KMC experience, I would just like to share one experience when we visited in one of our field. We met this is a photo of Ria. She's a very beautiful, healthy and active child. Right now sleeping cozily as her mother holds her for Kangaroo mother care. She was soon to turn 3 month old and now weighs 4 kg. She was born premature with birth weight 1.7 kg. She delivered at one of our remote PHC in Dhanura block, Gadchiroli. Her mother, when we asked, how did it happen? How did you take care of your child? So she was so quick to show the KMC position. She went inside, took out her bag, and showed us how the KMC position was done for her own child. So about Geeta, she was actually living in city Nagpur nearby, and when the COVID started, the health system disrupted in cities for a time being, and she thought better to move out to her village where she'll be taken better care. So she came back, but then delivered prematurely, and then ASHA worker ANM supported her at her home to provide effective breastfeeding and KMC, and now the Ria is surviving well and thriving well. So why home-based KMC is very important perspective of Gadchiroli. So if you could see in the left corner, there is a one shade hut prepared. So in Gadchiroli, in many tribal communities, mother is kept in separate makeshift house for 45 to 60 days after delivery, till the Barsa, the naming ceremony is done. Until that, she is not allowed inside the home. If you could see that is just makeshift arrangement, the plastic and sari are used to make that house. So 1.5 month, which is very crucial for newborn, she is not allowed in a warm, safe, clean place. So in such situation, also if you could see the girl is very young. We have been trying through our RKSK program and preconception program to address the age of marriage. But however, the challenges are still remaining. In such scenario where young girls are married early, such social customs are there, our field level workers are trying their best to provide home-based neonatal care. In such situation, even our health worker understand they are community which are resistant to come to the facility. These such challenges are there. Home-based KMC actually an a life-saving measure. For this young girl, it helps to breastfeed effectively. It prevents hypothermia, it prevents infection, and this child is also currently surviving well. Um, so it didn't directly start in the community. For last few years, our health facility, NBSU and SNCU staff nurses were trained for facility-based KMC. So they initiate the health facility at the health facility, giving a kangaroo mother care. The mothers are trained there. So this is Nidhi Koreti from one of our Dhanora block closer to the district headquarter. She was again 1.9 kg. She delivered at the health facility, and she was admitted in SNCU. She was taught KMC in the SNCU, and later when she went home, our Asha and Gata Pravartak is supervisor for Asha. So they did taught mother to continue home-based KMC, and this child was again surviving well. So it is again important for to continue home-based KMC in the community. At the facility also it should be given a good importance. It should be taught in the facility, so mother understand that this is not just a uh, as ma'ams earlier said, it is not just for poor people. It is actually a standardized good method to be picked up. So when we started implementing, these many photos started coming in our WhatsApp group, and we understand that for to implement home-based KMC in the field, repeated feedbacks are very necessary. As ma'am earlier mentioned, it is a low-cost method, but it's also very highly skilled method. So our field level worker had to be uh, feel confident to do this in the community. So some of them, sometimes the head was not covered, sometimes the feet were not well covered, sometimes it was not actually skin to skin contact and it was just holding as a upright position. We provided KMC bags whenever bags were not available, demonstrated with a cloth or sari. We are still at a long way to go in improvement in practices for the duration of KMC, but the idea has been gone into the community for the uptake. So we try to involve other family members, mother-in-law, fathers. I don't have a picture at that right now, but we have seen that fathers are also involved in the Kangaroo mother care. One thing worked is our ASHA worker, we already have a home-based neonatal program running in the district, and home-based KMC was added to it. So while doing the home visit, ASHA ensured that home-based KMC is also ensured. As ma'am earlier said, the kangaroo was concept was unknown, so we gave the example of monkey. KMC bags were called jholi or jhola to communicate message easily. So this is what we have been trying. So along with the training, which will come next, a KMC poster sticker was given to Asha to be pasted on the wall of their family. So it works as a reminder for family that this child needs to be given kangaroo mother care. Similarly, KMC stickers were given to be pasted on MCP card. Around total 14,000 KMC bags were prepared and distributed in blocks. So we gave it to the our ASHA supervisor. So they manage the distribution of this. I should must mention that district leadership took constant follow-up of this activity. They did through their supportive supervision visits, review meeting. Also, we have a district ASHA WhatsApp group where our supervisor keep sharing these photos, keep sharing their efforts. And one thing helped us is that we kept on appreciating what they did and keep correcting them in the skill, so which has helped them to feel confident about the practice. I just wanted to share the rangoli drawn by one of our Asha in the program, that she was very confident and happy to share this practice in their one of program. We have observed child survival. Also, we have been observing that child at the age of 6 months, or when we start complementary feeding, before that, the low birth weight child is achieving a normal weight for age status, or it is also helping to reduce malnutrition in the district. I will ask our district RCH officer to continue to share how we did this, what were the challenges faced in the implementation.
Thank you, Ashwini ma'am. Thank you, Vandana ma'am, for letting us know our efforts to the whole nation. Actually, Ashwini ma'am, can you, yeah, can you go ahead on the slide? Hello, am I audible?
Yes, Dr. Sami, you're audible. Ashwini ma'am, please proceed.
Yes, ma'am. So actually, this home-based KMC, as earlier, all our delegates had spoken to us about the hospital-based KMC and KMC practices. We tried a little different here. We actually go in the home-based because we have, as Ashwini ma'am, as you earlier told, that we have a lots of hurdles in our districts. Lots of things are in, lots of customization is there.
Sir, can you be a little louder and closer to the mics?
Yeah, sorry, ma'am. Yeah. So actually, we have taken this initiative to the home base more than that of institutional base, because we have a lot of hurdles in the community, a lot of traditional practices which are hindering actually to get into the hospitals. So what we did is actually in a state, we state selected 78 tribal blocks in Maharashtra total, and UNICEF has given a lot of support and the KMC Foundation of India also roll out the community-based KMC. And in this a special provision in budget allocation in NHM PIP 2019 was made for this training and field level worker training of this field level worker. So we have trained regarding 4 or 5 TOT persons, and they actually carried out systematic training in the field. Next, please. So what actually we did, the 5 district level officers were trained in Pune, and they actually handed the all training tools supported by UNICEF and KMC Foundation. And after they getting into the district, we have actually planned out 16 batches and trained 1245 ashas out of 1433 ashas and 123 block facilitator in the in the KMC home-based KMC training. So this actually was actually again helped by the UNICEF consultant and block monitors, program monitors, and in this NM, LHV, MO, initially they were trained, and later the ASHA and block facilitator, including Anganwadi Sevika, was included. We trained them including. Now, again, apart from this was again an institutional training center. We also again proposed that hands-on training in the field. So what we did was actually we shared, as Shwini ma'am told earlier, we shared materials, actually stickers, KMC pamphlets, and videos of KMC were actually shown in VHSND to the ASHA community participant like this through Pico projector, flip charts, and like this, so that the impact was made how it has to done, how it has to carried out. So this was the we have did in Gadchiroli district so far, and we are constantly doing this. Now this home-based KMC training, as you see this, we have trained the Asha and block facilitator in the left pictures, and then again every Asha was again have we take a revision in every meeting. We ask them what to do the meetings, and 5 minutes at least give some 5 minutes specific slot to the KMC for the MA, so that we as a ASHA go Anganwadi Sevika or block facilitator actually supervise, monitor, and help the mother to carry out those KMC practices in block. These pictures are from the Etapalli block and Chamoshi block. Same again though, we have, if you see that we have prepared a lots of charts, and we have again material tools, and the Pico projector shows that how to do that these practices and how to handle the baby and what minimal mistakes or what actually have to done. We have done this is a hands-on training practices we have did them. Yeah. And the last thing is again we have actually what we challenges, as you see that Kurma method side again the home delivery percentage is very large and huge amount in our district, and we are very trying hardly to reduce that number. In that systems again lots of things, lots of challenges and lots of problems, hurdles are we are facing. It's like that only mother are actually initially doing that, and again if you see the Kurma, no one touching the mother has to do all her duties in the fields and lots of things. It's like this. So what we did was we actually started community participation through MA program. If you see this picture in the far right, where the mothers were actually told their experiences in this VHSND session, that while doing these things, how beneficial is for her and her baby, and also at the same time how can we introduce this system to her mother-in-law, father-in-law, or any other family members, so that she gets some little rest also after delivery. So these challenges are still we are working on it, and we are actually rolling out very deeply in it. We are taking some we are having actually a positive result, but at the same time we also have some hurdles in it, and we are still going on work on it. Next slide please. Yeah. So same does again. We got a technical little KMC bags were not always suitable. So we actually the designs are not bad. So like 1.5 kg child is very low bulk. And again, as earlier man told that the is not the bag and other things is not. So whatever material or whatever we have in hand, we started with that, and we told mother to take actually these things and start giving the KMC. Then second afterwards, we have actually taken a review that how to increase that duration in the field, so that actually this KMC provided or providing to the members, it increase a little bit in the time. And again, Susan, a lot of many health workers thought that KMC is related to the weather. I mean, if it is a winter session, when we
So
have to
your
give,
voice is low again, Dr. Sameer. You have to be louder.
yeah. Sorry, ma'am. So again, many people, many healthcare workers were thought like that KMC is related to weather. Actually, they thought that, okay, this is winter and we need to promote a lot or give a more push in the winter season and less promoted in the summer. So we are actually re-emphasis on this things that irrespective of weather, the KMC is supposed to give to the LBW children. Again, we have found out that, as I told you, the ASHA supervisor, that is block facilitator, are very important link in this implementation of home-based KMC. So we actually training them constantly, their capacity building, and then again a lot of efforts were taking to train them, so that effective mentoring and hand-holding in the field and the field mobility, which is very important, it can be carried out. Again, at the same time, we need some digital locations separately for the KMC bags, as actually it was done, but previous following year budget allocations were not proper. So we started doing this locally, local custom-made forms where we or local custom-made other things were actually carried out like that. Then again, this was again as currently we are also carried out these things, and this LBW tracking data is also we are taking from the Anganwadi in the CAS related and other methods, and we are also developing low birth weight monitoring app like a Google Sheet like this, so that every person like MO, ANM, and a block facilitator should visit at least once to the
So your voice is mumbling again, sir. Please be loud, sir.
Yeah, sorry. Okay. Am I audible around now?
Yes, sir.
Yeah. Sorry. Okay, so we are actually tracking the data which is we got through the CAS and other methods, and we also making sure that every child, every LBW should be viewed by a medical officer, ANM, ASHA, Anganwadi once a month, so that at least we can refine the ongoing services, ongoing changes in the KMC and other things, so that at least we can minimize this malnutrition problem in our district, and also this mortality things in our district. Next one. So this is again, one of the picture, and this is the most precious picture where we went to counsel the resistance regarding the other problems, and where we find such a beautiful lady carrying her child in this top of joli, and that is also in a very heavy rainy season. So actually our tribal communities are used to hold child close to them, and they take up the practice of KMC once convinced about its importance and simplicity. So we are still working on it to generalize this thing in our whole district, and so that our motto to avoid the mortality rate and avoid this to address this LBW things, we can solve it as far as possible to us. With this, and thank you, and handing over to you, ma'am.
Thank you so much, Dr. Sameer and Dr. Ashwini. Without further delaying, I would like to congratulate you for such a piece of hard work in the community, and especially in the tribal communities, to promote Kangaroo mother care across the seasons and across the families. Before we get into the question answer session, I will be now sharing my screen with a short video on Kangaroo mother care at home. So all of you who have raised hands, please be patient with us and bear with us for another 7 to 10 minutes. And that will solve many of your queries of home-based KMC when you see a mother doing it at home. So I'm just putting my video on and I'll be sharing my computer sound. Hope you can see my screen.
मध्य प्रदेश में हर साल करीब 18,40,000 से अधिक शिशु जन्म लेते हैं। एक अनुमान के मुताबिक इसमें से 64,260 शिशु 1 माह के अंदर मृत हो जाते हैं। SNCU मध्य प्रदेश की रिपोर्ट बताती है कि इनमें सबसे ज्यादा 44% मृत्यु समय पूर्व जन्म या कम वजन के कारण होती है। वहीं बर्थ एस्फिक्सिया के कारण 25.8% और संक्रमण के कारण 16% बच्चों की मृत्यु होती है। ऐसी उच्च जोखिम वाले बच्चों के इलाज और मृत्यु दर को रोकने के लिए मध्य प्रदेश में 54 विशेष नवजात देखभाल केंद्र जिला स्तर पर बनाए गए हैं, जिनकी ऑनलाइन निगरानी की जा रही है। निर्धारित समय से पहले जन्म लेने वाले शिशुओं और बीमार शिशुओं को अल्पताप से बचाने के लिए विशेष नवजात देखभाल इकाई यानी SNCU में भर्ती कराना चाहिए। 1 जनवरी 2017 से 10 मार्च 2018 की जाती है और ये माता और शिशु की इस इकाई से जल्द ही छुट्टी होने के बाद घर पर भी लगातार दी जाए। जब तक कि शिशु का वजन 2.5 किलो से अधिक न हो जाए या वो परिपक्व आयु में न आए। कंगारू मातृ सुरक्षा एक ऐसी विधि है जिसमें शिशु और माता के बीच त्वचा से त्वचा का संपर्क स्थापित होता है, जो शिशु के शरीर में गर्मी पैदा करती है, भूख बढ़ाती है और किसी भी तरह के संक्रमण से बचाती है। यह शिशु देखभाल का हिस्सा है जो कम वजन के नवजात शिशु की मृत्यु दर को 50% तक कम कर सकता है।
तो यहाँ तो अपने पास नॉर्मल बच्चे रहते हैं, लेकिन घर जाके उनको उसके बॉडी का जो टेम्परेचर होता है कैसे मेंटेन करके रख सकते हैं, बच्चे का वेट कैसे गेन होगा, उससे कैसे बढ़ा सकते हैं और बच्चे का अटैचमेंट मदर फादर से कैसे अच्छे से रह सकता है, इसके लिए हम लोग KMC प्रोवाइड करते हैं।
SNCU से छुट्टी के बाद एम्बुलेंस में KMC अवस्था में शिशु को घर ले जाएं। समय से पहले जन्मे और कम वजन वाले शिशुओं की सुरक्षा का यह उपाय घर पर ही माता पिता या परिजन द्वारा घर में ही मौजूद संसाधनों का इस्तेमाल कर किया जा सकता है। इसके लिए जरूरी है कि शिशु के सर पर टोपी, पैर में मोजे और लंगोट बंधी होनी चाहिए। शिशु माता के दोनों स्तनों के बीच हो। शिशु के हाथ और कंधे मां को लिपटे हुए हो। शिशु का सर एक तरफ पलटा हुआ हो। शिशु का चेहरा, नाक, मुंह ढका हुआ ना हो। शिशु के दोनों पैर मेंढक अवस्था में होना चाहिए। KMC देने वाला शिशु के गर्दन और पुट्ठे को हाथ से सहारा दे। माता और शिशु को कंबल या गर्म कपड़े से ढांक दे।
कुर्सी, पलंग, जमीन या सोफे पर तकिए के सहारे पीठ टिकाकर बैठें।
कंगारू मातृ सुरक्षा प्रदान करते समय घर के जरूरी काम भी किए जा सकते हैं, जैसे चलना, बैठना, चावल चुनना, सब्जी काटना आदि। लेकिन ये ध्यान रहे कि शिशु सामान्य सांस ले रहा हो, उसका रंग गुलाबी हो और उसका शरीर ठंडा ना पड़ रहा हो। वह इस तरह से बंधा होना चाहिए कि फिसलने का डर ना हो। अगर माता को नींद आ रही हो तो ये उपाय नहीं करना चाहिए, या फिर किसी दूसरे सदस्य की निगरानी में करें और कंगारू मातृ सुरक्षा देते समय सीधा ना लेटें, पीठ टिकाकर आधा लेटें। ये विधि अपनाते समय इस बात पर गौर किया जाए कि इस्तेमाल किए जाने वाले कंगारू बैग, शिशु बैग, घर पर उपलब्ध कोई कपड़ा, शमीज, पेटीकोट, बनियान, लंगोट, शॉल, दुपट्टा या अन्य कोई भी कपड़ा इस्तेमाल किया जा रहा हो वो साफ सुथरा हो। कंगारू मातृ सुरक्षा देने वाला नहाकर स्वच्छ हो और उसे बुखार या खांसी ना हो।
चाहिए और दिन में कम से कम 5 से 6 बार देनी चाहिए, खास करके उन नवजात शिशुओं को जो 2.5 किलो से कम या समय से पूर्व वजन में हो। और इसे देने के लिए घर में नाना नानी, दादा दादी, माता पिता या परिवार का कोई भी स्वस्थ सदस्य दे सकता है। सारे चिकित्सकों से अनुरोध है, जैसे हमारे डॉक्टर्स, नर्सेज, एएनएम बहन, आशा, आंगनवाड़ी कार्यकर्ता, कि ये विधि वो ज़रूर सीखें और अस्पतालों में, पोस्टनेटल वार्ड में, एसएनसीओ में, साथ ही घर पे ये विधि कैसे देनी चाहिए, ये माता पिताओं को, नवजात शिशुओं के परिवार वालों को ज़रूर सिखाएं।
ये कंगारू मदर सुरक्षा के द्वारा हम बच्चों की ज़्यादा से ज़्यादा देखभाल कर सकते हैं। और जब मैं घर आई तो यही चीज़ मैंने घर पे भी फॉलो की और मेरे परिवार के सभी लोग इसको फॉलो करते हैं। इससे हम बच्चे का भूख लगना, उसका वज़न बढ़ना, मानसिक विकास होना, ये सभी चीज़ें इसमें आती है। और ये मेरे पति भी करते हैं और मेरी माता भी करती है और मेरे पिताजी हैं वो भी इसे फॉलो करते हैं।
जन्म के तुरंत बाद 1 घंटे के अंदर शिशु को स्तनपान कराना जरूरी है और 6 महीने तक केवल स्तनपान कराएं। शिशु को स्तनपान में अगर कठिनाई हो रही हो तो मां का दूध कटोरी या प्याली में निकालकर पिलाना चाहिए। केएमसी देते समय शिशु का तापमान देखते रहें। यदि बुखार हो या शरीर ठंडा पड़ रहा हो तो तुरंत अस्पताल ले जाएं। शिशु सुरक्षा की ये विधि दिन के हर एक पहर में 1 से 2 घंटे के लिए करना चाहिए, जैसे सुबह, दोपहर, शाम और रात को। जितनी बार माता पिता दे सके उतना नवजात के लिए अच्छा है। कम वजन के बच्चों को नहलाएं नहीं, जरूरी होने पर साफ कपड़े से पोंछें। शिशु को हाथ धोकर ही उठाएं। शिशु को बार बार ना उठाएं और बोतल से दूध ना पिलाएं। ये प्रक्रिया तब तक जारी रखें जब तक कि शिशु का वजन 2.5 किलो या इससे अधिक ना हो जाए।
Initiating kangaroo mother care early enough has the potential to promote early discharge from SNCUs. We encourage healthcare providers to use this video for self-training and training of mothers, especially at both facility as well as at community level.
आशा कार्यकर्ता पहले, तीसरे, 7वें, 14वें, 21वें और 42वें दिन गृह भेंट कर केएमसी देने के उपाय बताएं और शिशु की स्वास्थ्य स्थिति की निगरानी रखें। शिशु के बीमार होने, वजन कम होने, स्तनपान में दिक्कत होने, बुखार, दस्त या छाती में संक्रमण की स्थिति में शिशु को तुरंत एसएनसीयू में भर्ती कराएं। एसएनसीयू में भर्ती हुए शिशु की छुट्टी के बाद उसका 1 साल तक नियमित स्वास्थ्य जांच के लिए फॉलोअप लिया जाए। पहला फॉलोअप 8वें दिन, उसके बाद 1 महीना, 3 महीना, 6 महीने और फिर 12 महीने बाद।
कंगारू मातृ सुरक्षा नवजात शिशु में वजन को बढ़ाने, शिशु को गर्म रखने, संक्रमण को कम करने में सहायक है। सभी आशा, एएनएम, आंगनवाड़ी वर्कर कम वजन के नवजात शिशु का फॉलोअप करें एवं केएमसी के बारे में जानकारी दें। इस ट्रेनिंग वीडियो का उपयोग माता, परिवार के सदस्यों को केएमसी की स्थिति एवं उपयोग के बारे में जानकारी देने के लिए करें।
कंगारू मातृ सुरक्षा के परिणाम में शिशुओं का तापमान स्थिर होकर स्तनपान को बढ़ावा और संक्रमण से लड़ने की शक्ति के रूप में सामने आए हैं, जो अस्पताल में भर्ती होने वाले शिशुओं और माताओं की संख्या में कमी लाकर आर्थिक बोझ को कम कर रहा है। साथ ही शिशु और माता के साथ साथ केएमसी देने वाले पिता, दादी, नानी के संबंधों को मजबूती देता है, जो शिशु का मानसिक और शारीरिक विकास भी करता है और देता है हर चेहरे पर मुस्कान।
So, hope the video could answer some of the questions of how kangaroo mother care can be given at home by any other family member as well. I would like to move into the questions now. I understand some people had raised hand. Anil, can you please let me know if any hands are raised so we can take their questions first, and then I will read out the questions in the chat box. Anil?
hands are not raised. I can't see any hands raised.
Okay.
But
Okay, so
there are few questions in chat box.
yeah. So I'll take up the questions in the chat box first for the panelists. One of the questions initially is by Piyush G. Piyush G has talked about how can we monitor after in the follow-up period, and how practical is it to monitor the home visits. Do we have any follow-up visit mentoring, any checklists? So if any of the panelists would like to answer this question. During the home visits, if nobody's answering, I'll just take a go at it. During the home visits, the ASHA field worker has a checklist, and she has, and the mother has also given a discharge card after discharge. So these are the two checklists which are used for monitoring. Meghna G has asked the same question, so I'll skip that question. Ashish Sarkarji has asked, who is knowledgeable in the health system among health workers on KMC? So Alpana Maidi, would you like to answer this question, Alpana Maidi? Who is knowledgeable within the health system?
Repeat the question. Repeat the question.
Who are the health workers and who are the health workers in the health system who know about Kangaroo mother care and who can guide the community?
Actually, in the periphery, the ANM, they know the kangaroo care, and the supervisor also, and PHC level staff nurses, they are also giving training to the regarding the kangaroo mother care. Especially ANM, they are giving the training and they can help the mother to kangaroo care. And ASHAs also some places, not all places. Hello?
Yes, thank you, Alpana Maidi. So, lot of peripheral health workers are knowledgeable about Kangaroo mother care. Mainly, initially, we started the trainings with the SNCUs and the doctors and nurses of SNCUs. Now, like you saw in this training video also, this is being trained to used for all peripheral health workers, like Alpana Maidi suggesting, the staff nurses, the ANMs, the ASHA supervisors, the ASHAs. So many of these health workers are knowledgeable about Kangaroo mother care. Thank you, Alpana Maidi. Shatabdi has asked, how can you feed if somebody else is giving Kangaroo mother care in the family, then how do you feed the baby? So maybe Dr. Vani, Dr. Jyotsna or Dr. Purva, if you can address that question, please. Dr. Shashivani, are you there? Dr. Purva? Dr. Purva, can you answer the question, ma'am? Dr. Alpana Maidi, can you answer that question? If somebody else is
regarding the feeding of the
yes, feeding of the baby when somebody else in the family is giving KMC, how do you feed the baby?
Actually, hello.
Yes,
See,
yes.
the breastfeeding is required, and if mother is giving care, then only breastfeeding to be given. Otherwise, if other family member is, breast milk can be given, but preferably the baby would be put out and putting the mother's skin to skin contact and continue breast. It can also do. Otherwise, breast milk can be given.
Thank you. So basically, when a baby has to be fed, the baby will have to be returned to the mother for breastfeeding. But in case mother is not able to provide breast milk at that time and someone else is giving, then we have to express the breast milk in a katori and spoon and we can feed to the baby. But Dr. Alpana Maidi has also shared that in COVID-19, the precaution is about wearing mask, hand washing, and if the person is sick with any kind of flu or fever or cold and cough, we cannot give KMC to, that person cannot give KMC to the baby preferably. But if the mother has any symptoms of COVID or she has mild symptoms, she can continue to give with mask and with hand washing and all the precautions. So thank you, Dr. Alpana Mehdi, for the response. Dr. Harvinder and many other participants have shared poor compliance in the communities where they work, even after continuously counseling. So maybe if Gadchiroli team can answer that question, how they can improve the compliance of Kangaroo mother care in the community. Dr. Ashwini and Dr. Samir, if you can answer that question.
Yes, I would just want to add. Yes, we also feel the poor compliance issue. But one thing, what I mentioned in the presentation also, the field level worker who are supporting this activity, they need to be feel confident to provide this home-based KMC, because mainly in low birth weight child, mother is less confident, even field level worker are less confident. So generating that confidence and skill of giving KMC, that helps. Also, what we found in the field is mother's hands has to be free while giving KMC. If they keep holding the child with their hands, so they only give it after breastfeeding for some very little time. But if they are tied well with the cloth or any kind of material, they tend to give it for longer periods, because that's a usual practice for them. So these two things, if we add in our practice. And second, then there is a interpersonal communication by field level worker recurrently. Our community is little resistant to come to the facility, so when we mention that if they continue this at home, so they don't have to go to the facility and child can get better at the home, so they get convinced. So it's a struggle, but these things helps to improve the compliance. If Sami sir want to add something.
Yes,
So
ma'am.
thank you,
Actually,
Ashwini. Yes, Samir sir, do
yes,
you
ma'am.
want to say
Yeah.
add? Yes.
Yes, ma'am. A constant approach and constant training, and regarding the constant review in each level, it helps a lot and generate the confidence in our workers. And then, by leading them front workers, by leading them from front, we can go and have a dialogue with them, a dialogue with the mothers who is actually resistant to such scenario. Like from district, we are made a team of district level officer and district level supervisor. Those people go and actually address the resistance issue in the field. So this is also again helps to generate a confidence in our worker, and also at the same time the beneficiaries. And this is again actually a little by little make it easier for us to give the services to the beneficiaries. This is how we work in the culture now.
Dr. Alpana Mehdi, there is one more question in the chat box. Can donor milk be given if there is no human breast milk bank to the baby? So would you like to answer that question?
Yes, if there is no milk bank, then donor milk means same mother's milk to be given to the baby. That donor milk is not to be given because there may be so many addiction may be there, so there is risk. That's why other mother's milk without pasteurization cannot be given to the baby. If close relative, that is other, but legal aspect is there. So legally we cannot give the without pasteurization of other donors milk to the baby.
Sure. Thank you so much, Dr.
Am I
Alpana.
clear?
Yes, yes, ma'am. You are very clear. Yes, ma'am. Thank you so much. So, compliance issues, you also saw in the video that the mother was so well trained by the before discharge by the counseling, and also shown the position of KMC during discharge in the ambulance, and then she comes home and continues KMC. So it requires a lot of preparation when right from facility-based care and then post-facility-based care. And like Dr. Alpana Mehdi has also shared about the donor's milk, there are legal complications about it. So any close relative or any other person who can give and they are allowing, so you need to ask and take consent before giving donor's milk. But like Dr. Vani said in her presentation, breast milk is the best milk for the mother. So if the most of the times breast milk is not a problem unless there is a major illness or malnutrition, or if there is some issue like inverted nipples, but those also can be tackled, and you have to continuously counsel the mother, keep the position, and continuously support the mother for the breast milk. So thank you, Dr. Alpana Mehdi. With this, I hand over, since there are no other, Dr. Harvinder is there, she wants to make a comment. Yes, Dr. Harvinder, please, if you can unmute Dr. Harvinder Palaha. Harvinder ji, you want to make a comment? Can you please unmute her, Sphere Academy? So that would be the final comment, and then I would hand it over back to Sphere Academy for the final announcement.
Yeah, hi. Am I audible?
Yes, ma'am.
Yeah, very nice session, everybody. Dr. Vandana, Dr. Vani, excellent speaker, excellent content. I just want to make a comment about KMC being practiced in the tribal areas of Gadchiroli. We had gone there for an exposure visit a couple of years back, and we were told that in their home-based care of newborn program, they tried implementing the KMC very kind of hard. They tried, but somehow it didn't work out. The tribal women did not get the hang of it, so they found an alternative in the form of a hot bag or a warm bag. It was a quilted bag which had a bonnet and it had a zip from the neck to the feet, and the baby was placed there when the mother was like busy, could not hold the baby. And they said it has also worked well for them, and there was a paper also where the details were given. So I just want to know, okay, if that can be tried in scenarios where KMC may not be, possible for some reason.
The Gadchiroli team, would you like to comment on that?
Yes, ma'am. I have been working for like 1.5 years, like 2 years in Gadchiroli district. So I have seen those bags, which can warm bags, but they are used at our sub-center level, like where we actually have deliveries at sub-center also. So there, when the hospital say these bags were used because the radiant warmer was not available and the KMC was still not rolled out. But these bags are still sometimes used at the sub-center level. But in the community for last 1.5 year, we got the training from the state office and we rolled out home-based KMC again in the field. So this is the experience of last 1.5 year. I think Dr. Samir sir could add about the earlier experiences.
Dr. Samir, would you like to add?
Yes, ma'am. Yes, actually, Harvinder ma'am. Previously, it was a practice, but again, we has limited such practices in our sub-center level only. We are not providing this practices to the community base because of non-availability of baggage and a lot of other things. So we started and shifted this approach from that bags to the KMC practices earlier, last 1.5 years, as Ashwini ma'am spoke to us. But currently, we actually on institution level, in spite of this radiator, we can use that, but we are not actually continuing this practice in community.
Thank you, Dr. Samir ma'am. As you saw in the presentation of Dr. Vani, yes, Alpanadi, I'll just hand over to you. As you saw in the presentation of Dr. Vani also, Kangaroo mother care is human skin-to-skin contact is the easiest and most cost-effective method. Any procurement of bags will again require a budget. Here you are giving skin-to-skin from mother to baby. So it is advisable to actually promote Kangaroo mother care more and than use of such bags. Alpanadi, you wanted to add to this response. Please go ahead, ma'am.
Yes, I want to add that one. It is the humanized care. So skin to skin contact is more beneficial for the neurodevelopment of the baby. That's why we use the kangaroo mother care.
Absolutely. Thank you so
I totally agree. I'm myself a pediatrician neonatologist. I'm working with Dr. Rekha Udani to put together a booklet for ASHA trainers for KMC. So, but I just wanted to clear this point because we were told that this can be an alternative. So I just wanted the house opinion. Yeah.
Thank you, ma'am. Ma'am, there are evidences which suggest that these kind of bags and other things are not that cost effective. KMC is more cost effective than these kind of solutions. And those solutions, like Dr. Samir has clarified, they were given only for specific sub-center level where warmers were not present. So those were very specific interventions for specific periods. Thank you so much, ma'am. Thank you, Dr.
Thank you, everybody. Yeah, appreciate.
So
Thank
over to Spear Academy and for the concluding remarks. Thank you so much. Spear team, please take over. Spear team, we cannot hear you. Can you please take over? Spear
Hello,
team,
am I
can you
audible now?
yes, now you're audible. Please take over.
Yeah. Thank you, Dr. Vandana, for efficiently and effectively moderating this session. I thank each panelist for such an enriching discussion. I especially thank Dr. Shashi Vani from KMC Foundation India. I thank Dr. Jyotsna Srivastava, HOD GMC Bhopal. I thank Dr. Purva Gohia, Associate Professor GMC Bhopal. And a special thank to Dr. Halpana Mai Bera from Professor Government College of Nursing, West Bengal. Dr. Samir Bhansode, District RCH Officer, Gadchiroli, Maharashtra. Dr. Hashuni Majan, Health and Nutrition Consultant, UNICEF. Thank you all for such an enriching and valuable session. And before ending this session, here are some administrative directions. Your certificates will be ready in 24 hours. Please visit our website www.sphereindiacovid19academy.org and you can download your certificate by scrolling down and finding the name of today's session. It will be ready to download in 24 hours. However, if you are unable to do that, as some participant may face some technical difficulty, do not worry. You can email us at covid19academy@sphereindia.org.in. We will get back to you as soon as possible. Have a great evening and see you for the next session. Thank you all.
Thank you so much, and a special thanks to all the panelists. Despite their busy schedule, they have really helped us. And behind the scene colleagues, Dr. Kananika Mitra, Dr. Sridhar, thank you so much for all the support. And the UNICEF India team, Dr. Apurva, Dr. Vivek, and the whole India team. Thank you so much. And Spear Academy and NIDM team, thank you so much for the partnership with WHO and UNICEF. Thank you so much.